Why don't you send for Sampath as well as for Tanks or Jaydeep? Tanks are also the same
I will
way.
just share it. I'll just share it.
Reddy will join at what time? Dr. Reddy is joining at what time?
I think I saw his message that I got the link. He gave me a message.
Already 5.
Ma'am, I sent it to WhatsApp group. Just your personal number. Your WhatsApp, I sent it. Yeah.
Doctor, what is the other name you told?
Dr. Jaydeep Tank.
Yeah, I'll do that.
Yes, received it. Link. We will join later. Yes, link.
He's logged in?
No. He will be little 5 or 10 minutes late.
Okay. We can wait. Not a problem.
Banu, hi.
Hello, Chitra.
Hi, how are you, Banu?
Fine. Good evening to everyone. Hello.
Hi.
Madam is
Mammo, Shafiq anko sollade.
Good evening.
Good evening.
Hello, madam.
Good evening, Neeraj. How are you?
Hi.
Fine.
Fine.
Hello.
Madam.
Good evening, sir. Good evening.
Yes, madam. Good evening. Jairani, you are very smart, Jairani.
Arey babre, what is
Always,
it? I'm full of sleep. I'm putting a lot of powder to sleep. I don't know. My mind is overclouded. This little one and my daughter, they're really, I don't know. You all gone through that. Huh?
Still going. Still it is on the process only.
Continue.
Chitra madam.
Jaydeep is joining, so we will start after he joins.
You got the front page in a bigger way. Yeah.
Okay, Jaydeep is joining. So once he joins, we will start.
Yes.
Easier.
Good evening.
Hello, Jaydeep sir.
Good evening, sir.
Evening.
Good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir.
Good evening.
Good evening, sir.
Good
evening, Dr.
Good evening, sir.
Hello, Chandra.
Hello, Ramani.
Hello.
Sir, can we start?
Yes, we can start.
All of us are here, no? Right.
Hello, Bhanumati. Everything ready?
Hello, Chandra. Good evening.
Hello, Mr. Safi. Everything ready?
Yes, everything is ready and we are live, doctor.
Yeah.
People are seeing us. Yeah.
Good evening. Good evening, all friends. Respected Chief Guest, Dr. Jaydeep Tank. Guest of Honors, Dr. Revati Janagiraman, Dr. Ramani Devi, Dr. Anjalakshi, Dr. Sampath Kumari, and the Foxy Sexual Health Committee Chairperson, Dr. Neeraj. Senior faculties, my dear friends, presidents and secretaries of all Tamil Nadu and South Indian societies and all over India, and all the senior teachers and postgraduates and practitioners. It has been a great day in the Foxy Sexual Health Committee. We are having a very important webinar on sexual dysfunction. So we all know sexual dysfunction is one of the major healthcare, and it therefore deserves attention, consideration, proper investigation, and appropriate treatment. And if you look into all the guidelines, both national and international, even our Indian guidelines openly says that sexual problems are highly prevalent among men and women all over the world, and yet it is frequently under-recognized and underdiagnosed. Even among the clinicians who acknowledge this relevance of this addressing the sexual issues in their patients, there is a general lack of understanding sexual issues, what they come across. So there is a need for proper training, proper understanding, and to need an optimal approach for the sexual problem identification and evaluation and treatment. So the rational selection of therapy for the patients by the practitioners need a proper information about how to treat, investigate, and diagnose and treat them specifically in relation to their religion, to the custom, with the social setup, with their family, with the relationship, everything comes into role. So there is a need of a very big change in the clinical practice in view of this sexual dysfunction, which is one of the major problems women come across in their life. Though they say 70%, and if you look into the data, men sexual dysfunction in the women, still the latest study says that women suffer more than men, and all the treatments are more for men, which is less for women. So there is a need of a hour that all we practitioners and gynecologists, especially who look into the women's healthcare, should be aware of the treatment modalities of this important uh, healthcare issue, that is the sexual dysfunction. So I have a special thanks to the President, Foxy, Dr. Alpesh, and the Secretary General, Dr. Jaideep Tank, and the Vice President, Dr. Agni Agarwal, and Foxy Sexual Health Committee Chairperson, Dr. Neeraj, for encouraging us in this wonderful seminar to be an eye-opener for all the practitioners all over the country. With these few words, I have the great pleasure and honor in introducing the chief guest of this webinar, Dr. Jaideep Tank. Sashi, can I have Sir's CV? Sir don't need any introduction. He's the Secretary General of Foxy, and he has been a dynamic secretary of Mumbai Society, and he's a person in a chair, International Federation of Obstetric and Gynecology, FIGO, and he was the he's the present president of Mumbai OBGYN Society, and he's the ex-chair of publications of New Letter Committee, Asia Oceanic Federation of OBGYN, and ex-chair of Reproductive Endocrinology and Infertility Committee, and he is the working group for safe abortion also. And we have the great pride and honor, we all the Tamil Nadu societies, we welcome you, sir, for our webinar. And I would request you to kindly inaugurate and deliver your chief guest address. Over to you, sir.
Thank you very much, Dr. Jayadani. I'm audible.
Yes, sir.
Yes, sir, you're audible,
Yeah.
but you're breaking, your voice is breaking, sir.
Okay, is that better?
Little
Is
better.
that better?
Little bit
Better.
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 I'm actually in the
Voice is breaking, sir. Still voice is breaking. Maybe your internet
Okay,
is not.
possible. So I'm listening to video because that will, yeah. Dr. Jayadani, is that
No, sir, not clear, sir.
No, not yet.
No, sir.
Not yet.
if you will just, I think you should go ahead and I will rejoin. I don't want to waste anybody's time.
Now it is clear.
Now it's clear, sir. Now it's clear.
You can go.
So let me begin by thanking the Foxy Sexual Medicine Committee and its dynamic chairman, Dr. Neeraj, for inviting me as chief guest for this webinar. I would also like to appreciate the Tamil Nadu.
Not audible.
Yeah, some issue with the net. No problem. Yeah, you can go ahead with the next one. Hello. I think he is Dr. So
So, sir, you can go ahead and
yes. No, he is there. Let me.
Is that a
Yes.
better connection?
yes,
now you
yeah,
better.
now it's better, sir.
Okay, I'm really sorry about this. I'm in the operation theater actually, and that's why I'm having some network issues. I apologize for that. Let me thank the Foxy Sexual Medicine Committee, led by its very dynamic chair, Dr. Neeraj Jadhav, someone whom I have known for many years, and I'm extremely happy with the way he's progressing and the work that he's doing. And the Tamil Nadu OBGYN Societies Federation and the president, Dr. C. Anjalakshi, who's also a guest of honor today. I must acknowledge our president, Dr. Alpesh Gandhi, the vice president in charge of the committee, Dr. Ragini, and of course, very well-known guests of honor whom I have the privilege of being sharing the stage with, Dr. Revati Madam, Dr. Ramni Devi Madam, and Dr. Sampath Kumari Madam, and of course, Dr. Anjalakshi Madam. Uh, Dr. Jairani, thank you very much for that extremely kind and generous introduction. You are doing such a great job with this wonderful series of webinars along with the Sexual Medicine Committee and Dr. Neeraj Jadhav and Dr. Padmini Prasad. I think this is the third or fourth one which I am attending, and I'm always pleasantly surprised by the kind of attendance and the wonderful topics that you have put up. So you have some really wonderful topics today: rejuvenating sex life after 40, infertility and sexuality, a connection which really is not talked about enough, erectile dysfunction, sex and sexuality in pregnancy, and then you're finally going to have a panel which is going to be moderated by Dr. Jairani on decoding female sexual dysfunction. Paired along with these topics are some very eminent speakers. There is Neeraj, Dr. Premlata, Dr. Narayan Reddy, and Dr. Padmini Prasad. And of course, the panel has some wonderful panelists with Dr. Krishna Surendran. I believe Dr. Krishna has been installed recently as the president of the Nagarcoil Society, along with Selva as the secretary. So congratulations to both of you. And Dr. Rajapriya, Dr. Bhanumati, Dr. C. Raja, and Dr. Priya. I must also acknowledge and thank the chairpersons and the session coordinators, Dr. Chitra, Dr. Chandra, Dr. Mary, Dr. Umayal, Dr. Sumati, Dr. Vidya, Dr. Radha Madhvi, and Dr. Shantirani. And of course, your vote of thanks is going to be delivered by someone who's just delivered a fantastic conference with the OGSSI, and that's Dr. Vijay Lakshmi Gnanasekharan. I believe that sexuality is a common problem. I believe that it's an under-discussed problem, and I am quite sure that webinars like this and programs like this will certainly help to curb the myths and break the taboos which surround this topic. So thank you again, Neeraj, for inviting me, and I wish you all the very best for this webinar. Thank you.
Thank you, Dr. Devi. Now it's my proud privilege to invite our guest of honor, Dr. Revati Madam. If it's okay, can we have a better TV?
So, Shafi, Madam Dr. Revati Janagram CV.
Yes,
Can you
Dr.
share? Yeah.
So, Madam Madam was the vice president of Foxy South Zone in 2016. She is the former director of IOG Chennai and professor in Emirates, the FGR Medical University, and she has so many other qualifications. So I thought so because we don't all of you know very well Dr. Madam. So I invite Revati Madam to say a few words about sexual medicine. Welcome, Madam.
Thank you, Dr. Neeraj, for your kind words. Good evening, dear friends. It's always my pleasure to be a part of the CMEs organized by Dr. Jayarani Kamaraj. I used to enjoy her ferticons, which always make me feel very proud of her. As a teacher of Jayarani, I feel at the time, Indra Polidil Peridokum Tanmahane Sandro Neneketatai. That's the grand way in which she does her academic activities. And today's webinar on demystifying female sexuality is a different kind of one. Sex is no longer a taboo topic. Human female sexuality encompasses a broad range of behaviors and processes, including female sexual identity and sexual behavior, the physiological, psychological, social, cultural, and religious aspects of sexual activity. First of all of us practicing gynecology should be aware of the various problems of sexuality. Only then we know the approach to these problems, and we have to create awareness among the patients also. And women's sexuality can change over time. As you can see from the topics chosen here, sexuality in 40 plus and during pregnancy and so on. I'm sure the audience is going to gain a lot of knowledge on various aspects of sexuality today, which they can never get from any other webinars. All the best, Dr. Jairani and also Dr. Neeraj, Chairperson Foxy Sexual Medicine Committee, and I wish the conference a grand success. Thank you.
Thank you.
Thank you, madam. Thank you for your nice felicitations. And we owe a lot to you, madam.
Thank you. Thank you.
I have the great pride and honor, and I have a great pleasure in introducing Dr. Ramani Devi. Madam is the managing director of Ramakrishna Medical Center, and she has won nearly a dozen medals in her UG and PG periods, and she is the winner of Professor C. Dhawan Prize. And Madam presently is the Vice President Foxy of South Zone Foxy, and she was the chairperson of Endometriosis Committee Foxy 2014 and 16, and she has done a wonderful work in endometriosis, dedicated her energy, her knowledge, her complete dedication to endometriosis, and every woman in the world should always look upon her as a real motivator for the endometriosis treatment guidelines, which she has empowered in her with her great effort. And we are very happy to have you, madam. We welcome you, and we would request you to deliver felicitation of this webinar.
Thank you, Dr. Jairani, for the kind words. I am really honored to be a guest of honor for this very important webinar series, which Oxy and the Sexual Medicine Committee of Oxy is doing under the leadership of Dr. Neeraj Jadhav and Dr. Jeremy Kumaraj. When you consider the health of a woman, WHO also says the women health includes sexual health also. Like Madam has said already, it is no more a taboo, but it is only up to the consultants to listen to the words of the patients, because very often the patients, they feel very shy to discuss with the doctor regarding their sexual dysfunction. And most often, if you go into the details of an infertile couple, almost 50% of the problem would have been solved with a simple history taking, where sexual dysfunction plays a major role in both the couple, and just giving them some tips, some advices will be sufficient to overcome the infertility. So again, off late, we have a lot of newer evaluation of sexual dysfunction, both in male and female, though at least to some extent, male dysfunction is often spoken about, but female dysfunction still remains in a shadow. I think it is the duty of the physicians to empower these women who are so pathetic with history of with complaints of sexual dysfunction to come up openly and then discuss with them. And I personally feel even many of the senior gynecologists are quite unaware of the happenings in this particular field, sexuality. And this sort of webinars, I think I am also attending this for the third webinar I am participating. This webinar series should impart knowledge first to the consultants, first to the physician, then only they can spread the message to the patients. So I wish Dr. Neeraj and Dr. Jairani Kamaraj for spreading the message, spreading the knowledge about sexuality and female and sexual dysfunction. I wish this webinar a grand success, and I wish in future also you bring about so many webinars so that everybody all over pan-Indian doctors can be educated by this. And I also congratulate Dr. Padmini Prasad for the lot of counseling what she does for the couples who suffer from sexual dysfunction. Wish you all the best. Thank you for the opportunity given. Thank you.
Thank you, Ramni. So now it's my proud privilege to invite our next guest of honor, Dr. Sunanda Lakshmi Madam. Dr. Mr. Safi, can you share Madam CV? Madam is the Vice President of Foxy. No, but next one. Anja Lakshmi Madam. Madam is the recipient of the Best Doctor Award from the IMA. She is a retired professor of OBGYN from the Madras Medical College, presently working as a professor and HOD in the Mata Medical College, and presented number of papers in national and international conference. And she is the immediate past president of OGSSI and current president of the Tamil Nadu Association of OBGYN Society. So we welcome you, madam, and please bless us with your few words of blessing. Madam. You have to unmute, madam.
Madam, unmute, madam. Anjalakshmi, madam.
Okay, you can unmute, madam.
I'm just checking.
Can you help to unmute, madam?
Yeah.
Hello?
Yes.
Hello, audible, ma?
Yes,
Yes,
madam.
madam,
You're
you are
audible, ma'am.
Okay. The respected Chief Guest, Dr. Jaydeep thanks the efficient Secretary General of Foxy, and the guest of honor, Dr. Revathi Janagraman, the past Vice President of Foxy, Dr. Ramni Devi, Ramni Devi, Vice President of Foxy, and Dr. Sambat Kumari, the Vice President-elect of Foxy, and distinguished faculties, my dear delegates, and the chairperson, Dr. Neeraj. I give my good evening to everyone. As the president of TNFOG and the first event of that after formation of that, I am very much pleased and honored to facilitate the CME program, Demystifying Sexuality, a focus on female sexuality, convened by Dr. Jairani Kamaraj and Dr. Neeraj. WHO defines health as a state of physical, mental, and social well-being in which disease or infirmity are absent, which includes the psychological and sexual health. Though the gynecologist or the primary physician for women, our ladies, they will not come out with the sexual problem, though it is present more than 70%, as Jairani has mentioned. And if they come out also, the gynecologist, they will not listen to them. That because one is the inhibition and other one lack of knowledge. Thus, the sexual medicine gets the least preference, and the women, they suppress the problem, suffer, and they develop psychological problem, which can lead on to somatic disorders also. See, the relationship I have with Dr. Jairani is more than a teacher-student relationship. And she has taken this part of the gynecology as a passion, apart from her expertise in the reproductive medicine. And she involves herself in the CME programs of sexual medicine to educate her fellow gynecologists, and she is trying to break the inhibition in the medical fraternity and the patients also, so that there should be an improvement in the sexual health. I hope and wish and pray that the sexual medicine develops into a subspecialty. I wish all the success for this program and congratulate Dr. Jairani and Dr. Neeraj for this endeavor. Thank you. Jai Hind.
Thank you, madam.
Thank you, madam.
Thank you.
I have the great pleasure and honor to introduce my good friend, Dr. Sampath. It comes like not Sampath Kumari, it comes as Sampath because we usually call her as Sampath. So it gives me great pleasure to introduce her, who is the vice president elect of Foxy, and who was a very dynamic adolescent committee chairperson who has traveled so much all over the country to do a lot of work for the awareness of the adolescent programs. And she has done a lot of wonderful activities in the adolescent health. And very importantly, she will be known in the adolescent history of Indian adolescence history. And I'm very happy to have her here to felicitate this webinar. Over to you, Sampath.
I had a privilege to work with the madam, so I'm very happy to meet.
Yes, Neeraj. Thank you, Jairani and Dr. Neeraj. Dear friends, colleagues, and well-wishers, good evening to one and all. It is deeply gratifying and humbling that Dr. Jairani has chosen me along with stalwarts like Dr. Ramani Madam, Dr. Revathi Ma'am, and Dr. Anjalakshi Ma'am as a guest of honor in this August gathering. I thank the organizer, Dr. Jairani, an energetic and very talented person. So is Dr. Neeraj Jadhav. He is very promising and enterprising person, whom I know him as he told from my adolescent committee chairperson. He was the West Zone coordinator for my committee. He was doing fantastic work, and he is continuing the same work with now with the Foxy Sexual Health Committee. Congrats, Neeraj, and all the best to Dr. Jairani. Sexual dysfunction during the post-reproductive phase is something no one is happy to discuss about. It's really proud, very proud to know that Dr. Jairani and Dr. Neeraj as a chairperson is doing fantastic work. Really, all the best for the success of your CME. You will be continuing, I know, the program throughout your committee, and you should get the best committee award also, Neeraj. All the best. Dr. Jairani will do a lot of work in this. Thank you. Thank you.
Thank you, Sampath.
All the best, Jairani and Neeraj.
Thank you. Thank you, Sampath, and thank you all the chief guest felicitations. And we really honored to have the guest of honor, chief guest, to be here to felicitate us to have a wonderful CME. And we assure you all that we will work for the women's sexual health of India with all our activities. And definitely we'll bring a lot of knowledge to all the gynaes and all the practitioners to know about the women's sexual health, which is very important, as rightly said by Dr. Ramani Devi, Dr. Revathi, Dr. Sanjalakshi, and yourself, that it is a very important step that as a committee, we all work to get the best sexual health services for all the Indian women. With this word, I thank all the dignitaries, and I thank you one and all, and we are now opening the scientific session. So we are now moving on to the session. The first session, I have the great pleasure and honor to introduce the coordinator of the first session, Dr. Chitra, who is the professor and unit chief of OBGYN, PSG Institute of Medical Sciences, Coimbatore. And she had an affiliation as the president of Kovai OBGYN Society. And she's the scientific committee member of UO Foxy 2019. And she's the member of IUGA and ISUOG. And her specialties are urogynecology and high-risk pregnancy. Over to you, madam, to coordinate the first session and introduce the chairpersons. Thank you, madam.
Thank you, Dr. Jairani and Dr. Neeraj, for this wonderful webinar. In fact, this is a much sought, very, very important problem that all of us face, including all of us. Every day in, day out, we have this problem, but none of us are courageous enough to take up this and talk to this. So it's very important that this has been told, that we have a webinar in this. Everybody talks about fetal medicine, endoscopy, etc., but nobody has the guts to have this sexual medicine. So I really congratulate both of you for this wonderful webinar. And it's my pleasure to introduce our three chairpersons for this forthcoming first session. First one is Dr. Chandra. Dr. Chandra, she has many firsts to her. She's the first person to have organized the Salem OG Society, and she's a founder member of Namakal Society. She has many gold medals to her credit, and she's always a very, very pleasing personality. Uh, can I have the next person? Welcome you, ma'am. It's my pleasure to introduce Dr. Chandra. And next we have Dr. Mary Genova. She's the president of Virudhunagar RSSOG Society. She's graduated from Madurai, and she's running a multi-specialty hospital in Sri Villiputtur. And again, madam is also a gold medalist. She has many gold medals to her credit. And next we move on to Dr. Umayal. She's always a very smiling person. I see her in all the webinars, and that's why I become very, very friendly with Dr. Umayal and Dr. Chandra. I see them so often. So welcome you, Dr. Umayal. She's from Tambaram West, and she's a trained infertility specialist and obstetrician. Now, in this first session, we have two lectures. One is one is by Dr. Premlata, who will be talking about infertility and sexuality, and Dr. Neeraj will be talking about the first topic. So over to the chairpersons to conduct this, to take it forward from here. Dr. Chandra.
Yes. Good evening, everybody. Thank you, Win, for the nice words, Dr. Chitra. And at the outset, I would like to thank Dr. Jairani, convener and chair Foxy Sexual Health Committee, Dr. Neeraj, for giving us opportunity to take part, our Namakkal society, to be part of this webinar. And we have certain priorities during different phases of life. Once our family is completed, sexual life becomes least important. But sexual life doesn't stop and should not come to an end. So Dr. Neeraj is going to talk about sexual life after 40s. So Dr. Neeraj, slide CV, please.
I'm leaving now. Okay.
Dr. Neeraj, Shafi, please, okay, Dr. Neeraj.
Yes, Doctor. I'm flashing it once.
Yeah. Yeah, it's my proud privilege to introduce Dr. Neeraj. He is the chairperson at present, Sexual Medicine Committee, Foxy 2022, and he was a secretary, Rajkot Menopause Society. He was a past president, Rajkot Obscine Society. He was faculty at state at many national conferences, and he has contributed to various Foxy publications. Now, the forum is yours, Dr. Neeraj, please.
Thank you, Chandra madam. So I'm going to talk on the rejuvenating sex life after 40. It's more of a non-academic talk. It is visible, madam?
Yes, doctor.
Okay.
Yes, sir.
So, rejuvenating sexual life after 40, it takes time, it needs care, and it needs effort. For many people, life over 40 is pretty good. Your career is better than ever, and your confidence is an all-time high. However, the sense of time spare no one, and for some over 40 folks, life in bedroom can change dramatically as the year passes, and not always for the better. So, whether your sex drive has taken a total stride or an innocent catnap, these 40 plus scientific and expert approved tips and tricks will boost your mojo in no time. First of all, understand sex. Sex is important. You would be surprised at all the unexpected health benefits regular sex offers. In addition to improving your mood and whistling your best time, sex can even help you live longer. One way to do is by exploring both solo and paired sexual activity to stimulate your major endocrine axis and nervous system, which manage all your major body functions. The sex hormones are involved in maintaining muscle and bone mass, male and female characteristics, sex drive, as well as certain cognitive functions and memory. Understanding how your body works is a good first step into truly enjoying sexual activity. Ensure you are in optimal health. It is important to remember that the sexual health and general health go hand in hand. Prevention and treatment of typical chronic disease are clearly associated with better sex life. Go back to the basic. When people have let there be a growing distance in their intimacy, and this can be as simple as kissing and cuddling, being affectionate and intimate with one another becomes awkward. You just need to go back to the basics of where your attraction for one another started and work your way up. In other words, act young, make out, but don't think of sex, create anticipation and attraction, and the rest will grow and follow. Set the mood with the foreplay. You have most likely heard about the importance of foreplay. Both male and female experience full pleasurable orgasm when sexual arousal and desire were picked through the foreplay. But this foreplay doesn't have to be sexual in any way. The relaxation of getting a massage, spending time together, or enjoying a candlelight dinner definitely helps spark your sex life if you are having a drought. Wear socks. Okay, I agree that this one sounds bizarre, but a study in the Sweden found that a woman had more difficulty achieving orgasm when their feet were cold. This is definitely a good reason to ask your partner for a relaxing foot massage before foreplay, or at least to get toasty together by the fire. Make a bedroom bucket list. Doing this activity over a bottle of wine with a plan to carry out it over next 6 or 12 months. Just brainstorming and discussing what you have always wanted to do and never brought up is sexy. You can make an oral list, a written list, or put your wishes on note cards in a kiss bowl, and once a week, once a month, dip in and do what's on the card you pull out. This is the kind of thing that works at any age. Rent a hotel room for a night. Hotel sex is tried and true. Your home has the implications that aren't sexy. From your kitchen that reminds you of all the dishes that need to be done to your bathroom, where you might find those pesky beard trimming you have been complaining about. Getting out of the house, out of the town, or out of the country, if you can afford to do so, is a great way to spice things up. If it works, and it definitely will work, make it a regular thing. Find out what's holding you back. Start working backward from what may be stopping you from having a great sex life you want. If it is stress, break it down and name your top three stressors and then knock them out. If it is feeling that you are a little overweight, join a gym and get rid of that extra weight by working out and then eating well. The gym itself can be a libido stimulator. And if it is kids, get your kids at a regular sleepover date at a relative house. Masturbate. Masturbation is the mainstay of both modern sexuality and modern sex therapy. Not only does it help you understand what you like and what feels good for you sexually, but research also suggests that it's good for your health. Masturbation is a means to kindle our eroticism, explore our erogenous zones, and enhance our libido. The better we love ourselves, the better we can love others. Make sure you know your letters G, A, and O. No, I'm not talking about the basic alphabet, but rather the lesser known hot spot similar to G spot. There is another spot named S spot, past the G spot, just above where the cervix is located in the vagina, and another one opposite side below the cervix known as a O spot. If your partner learn how to properly stimulate this area, both with their fingers and through the intercourse, it will take you to the completely new level of experience. Schedule sex. It might sound unsexy, but putting sex on the calendar is one realistic and approachable way to ensure that it actually happens. If one partner is a number person and the other isn't, this can make the discrepancy between the how much sex one person wants and how much they are getting, and making things more complicated. Coming to an agreement on a range of time in which you both are willing to try and have sex. It can be once a day, once a week, or once a month, but try and stick to it. We are embarrassed and uncomfortable talking about our personal needs and desires. However, failure to discuss this often leaves one or both partners unfulfilled. To be a partner is to be able to open with each other, so you both should be able to express your wants and desire. Getting over the awkwardness hurdle by having a discussion with your partner about what works for you and what doesn't. You will be happier and more satisfied if you know how to fulfill each other. Avoid criticizing your partner's sexual performance. Sex is a vulnerable act. Many people carry with it a series of concerns and anxiety about their performance and ability to please you. To tell your partner you are unfulfilled, to criticize their performance, or to take it personally when they are struggling to perform only worsens the situation. The majority of male sexual issues are based on the anxiety, so this type of comment only adds to their anxiety and insecurity. If there is a need that you want to meet, there are far better ways to express them. Incorporate a little fantasy. If you or your partner is hesitant to try some of the foods you might have seen in the 50 Shades of Grey, you might want to reconsider. The mind is the foremost erogenous zone, so a stimulated imagination can powerfully steer the body to the sense organs. Sexual fantasy can be beneficial for couples in relationships. Touch each other in a non-sexual way. Physical touch that does not involve sexual activity is just as important, if not more important, than having sex with your partner. Multiple studies have shown that level of oxytocin, means love hormone, profoundly affects how you feel about your partner. It only makes you feel good, but it counteracts the effect of cortisol, the stress hormone. Leave your to-do list at the bedroom door. You know that seemingly endless list of things you have been meaning to do. There is a no plus for them in the bedroom. You shouldn't be thinking about your responsibility during sex. One of the biggest killer of arousal is responsibility. The more you can dissociate from your task and responsibility, the more you will enjoy sex with your partner. Use reliable contraception. Feeling confident about the protection from pregnancy is important for those who don't desire such. Remember, libido for women starts in the brain. So if you are concerned about pregnancy, you may have less desire. Do your Kegels. Kegels are extremely important for genitourinary health. In fact, research has found Kegels to be helpful in improving orgasmic response as well as addressing SUI and pelvic organ prolapse. Unfortunately, even though this simple exercise doesn't require a gym membership, it is either infrequently performed or not done correctly. 3 sets of 15 repetitions 3 times a day, holding each Kegel squeeze for about 5 seconds is the better way to do Kegel exercise. Take estrogen. So we all are aware about the how estrogen is important for sexual health. So I don't have to stress much about its role in the sexual health. Stress less. Chronic stress is a serious libido killer. While relieving stress isn't always easy, it's something to be aware to help to improve the things sexually. Exercise. Exercise is important for sexual health. It increases stamina, which is important when it comes to sex. Exercise also improves body image and mood, which therefore improves sexual functioning. The more confident a woman feels about her body and the better her mood is, the more likely she will be able to desire sexual satisfaction during the act. Maintain a healthy diet. As saying goes, you are what you eat. If you are eating fattening, fried food, you will feel lethargic and will most likely gain weight, which probably won't put you in the best mood for sex. There is some evidence that diet, especially Mediterranean diet, can positively impact the sexual function in women. When it comes to diet, loss of weight improves body image, which in turn can improve the sexual function. Season with saffron. One really exciting possibility for dealing with the reduced libido from the antidepressants comes from the unexpected source, the spice saffron. Saffron has historically been considered an aphrodisiac, but only recently has it gotten attention for helping with the depression and helping women to recover from the low libido caused by the antidepressant. Eating apple, it's loaded with the good for you nutrients like antioxidants, flavonoids, and dietary fibers. It also helps to boost your sex drive. One study published in the Journal of Archive of the Gynecology and Obstetrics linked apple consumption to the better sexual satisfaction in younger women. Quit smoking. Smoking can be a huge buzzkill for your sex drive. Smoking causes vasoconstriction, which can diminish the natural lubrication in the vagina during arousal. And in male, it can lead to erectile dysfunction as well as premature ejaculation. Cut back on alcohol. It's hard to be motivated to do anything when you had a few too many drinks, let alone have a sex. Reserving alcohol for social occasion rather than a nightly habit and to do something better for your health is to have sex. Seek out career advancement. You might be thinking, what on earth does my job have to do with my sex life? Well, to your surprise, it very well may be causing you lack of enjoyment in the bedroom. Poor self-image or lack of personal satisfaction from your job, especially if it is causing you stress and you are in a bad work situation, can affect more than the buzz. It can affect your sex drive too. Take control of your life and you will feel like having more sex. Treat mood disorder. Address the underlying mental health issues such as depression and anxiety, and some medication also used to treat the mood disorder also reduce the affect the sexual function. Seek help for the sleep apnea. Several studies have backed the effect of sleep apnea on sexual health. And drink more water. You should be drinking your fair share of water daily if you want to stay healthy, and same goes for sexual health too. Numerous medication can cause lower the sex drive, including antidepressants, birth control pills, antihistamines, opioids, and related pain medication, as well as blood pressure medication. So you are taking any of such medication, talk with your doctor. Prioritize sleep. Getting the right amount of sleep, you need to feel restful and rested is so important for your sexual health as well as your overall health. Practice mindfulness. This is an important tool when it comes to sexual function, especially for women struggling with the issue related to sexual arousal and orgasm. Women especially are multitaskers, so their minds are often in three different places at once. This becomes problematic in the bedroom when focus on the sexual act is important for intimacy and sexual satisfaction. Use lubricants. Sexual lubricants aren't only useful for those experiencing vaginal dryness. They are also invaluable for your sex life. Make a lusty playlist. Having a great sex to good music can enhance your experience in the moment, and hearing the music again later can actually trigger your arousal center. One study found that the music and sex trigger the same area of brain. Keep electronics out of bedroom. More and more of us are on multiple electronic devices and spend many hours. There is hardly room for intimacy of any kind, let alone sex. Getting update and knowing the status of your partner should trump all other forms of social media each night. Start a habit of plugging your phone and other device outside the bedroom so you can focus on your partner. Build anticipation with sexy text. Believe it or not, sexting is not only for the young and impressionable. It is a great way to communicate with your significant other throughout the day and can serve as a form of foreplay. Because the brain is the largest sex organ, it is important to get the mind thinking about sex far before sex actually begins. Lingering and long wear tends to be neglected, but it's one of the easiest and most effective ways to spark your intimate and romantic life. You will be surprised how much sexier you feel when you take action toward making yourself feel ready for the action. Wear high heels. A pair of kicks had a potential to work wonder for your sex life. Drink more coffee. Your daily cup of coffee is surprisingly healthy and it might do both and wake you up and help you stay on the track with your to-do list. It might also help increase your libido. Try a blindfolded surprise. Sometimes just the anticipation and excitement of not knowing what will happen can really amp things up. First, do a little homework. Each partner thinks of things that might be exciting to do to the other partner if he or she were blindfolded. Do search online for exciting idea and just don't tell each other what your plans are. Learn and practice edging orgasm. Edging orgasm involves stimulating oneself to the threshold of spasm and then releasing, but not getting to the point of full body orgasm. Edging orgasm is also known as having belly orgasm, wave of neuromuscular euphoria occupying the genital area and spreading sexual energy into the core and extremities of the body. Turn off TV. TV may be lower your chance of having sex. Couple who had a television sets in their bedroom had a half as much sex than those who don't have TV in their bedroom. Take turns meeting each other's needs. Share with each other your sexual desires and fantasies. Take turns fulfilling each other's personal needs, and you have created an openness and balance in the relationship that was not there before. Knowing that you are making your partner so fulfilled can be satisfying in and of itself, and knowing that the need and desire of your own is going to be fulfilled can be arousing to you in general. Seek expert guidance. Sometimes even exercise and stress reduction may not be enough to put the spark back in men's sex drive. When this is the case, an underlying medical condition could be blamed. Plenty of men experience conditions that can affect the libido, and there is no shame in seeking treatment so that you can back to the sex life you want. Smile more often. It might sound simple, but simply flashing a grin can some spark back into your sex life. Smile communicate physical health, mental well-being, love of life, being present in the moment, and being happy inside our body. Smiling is sexy, smiling is beautiful, smiling makes us attractive. So go ahead and greet your significant other one with an ear-to-ear grin. Life really does begin at 40. Up until then, you are just doing research. So thank you for your present hearing. I hope I finished in time.
So thank you, sir. You're just finished on time, madam. That's great.
It was a
Doctor.
nice presentation. Thank you, sir.
Dr. Mary would introduce the next speaker, I think. Madam, Mary, madam.
Yes.
Please introduce the next speaker, madam.
Okay. I'm very proud to introduce Dr. Premlata. She was my senior when I was studying in Madurai Medical College. I haven't seen her without book, always discussing something with all friends. I am a fan of her, really. She's a consultant now. She's a consultant HOD in Methos Multi-Speciality Hospital, former professor of OG and director of Institute of OG, Madras Medical College. She has presented many papers, published many articles, active member of FOXY. She has expertise in tubal microsurgery, authorized book, undergraduate manual for clinical cases. I invite you, ma'am, to present your topic.
Thank you, Genova. Actually, it's really, I'm very happy to be introduced by you. My all undergraduate memories are there, seeing you in the thing. I was just trying to talk to you. Thanks for the nice introduction. At the outset, good evening to everybody. I'd like to thank Dr. Jairani Kamaraj for the wonderful, chance given to me, because it's nearly a decade back when we were actually called to be chair the session in our international conference in sexuality. I think it's 2009 or 2010, I don't know. That is the time we went as a chairperson to the hospital, in the conference. And after attending this, I was so shocked the way the people were talking about the sexual medicine, which is completely new to us, actually, we should say. Because everybody were talking, there were 3 sessions in each session, there were 3 halls in each session, they will be talking about all about sexuality. And I came back and told my postgraduates, we have to learn a lot in sexual medicine. As a professor, I was learning at that time in 2009. I think I'm over a year and she is going on inviting us with so many topics in sexual medicine. Thanks, Dr. Jairani. Now I'll go to the topic on sexuality and infertility. Sexuality, as you all know, it is not just an act of physical act of intercourse. It is not just the state of being physically able to perform a sex act or to conceive a child, but it's an integral component of human life with multi-dimensional content. Actually, when you say sexuality, it influences self-identity and communication, sharing pleasure, deepening intimacy, and may lessen stress in one's life. When you say human sexuality, it is a way which people experience and express themselves sexually. This involves biological, erotic, physical, emotional, social, and spiritual feelings and behaviors. When a WHO definition of sexuality is actually, it is experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, and behavior practices and relationship. While sexuality will not include all these dimensions, not all of them always experienced and expressed. It is about sexual feelings, thoughts, attraction, and behaviors towards other people. And what is sexual health? A sexual health is a state of physical, emotional, mental, social well-being related to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. And sexual health is fundamental to the overall health and well-being of individuals, couples, and families. Sexual health, when viewed affirmatively, it requires a positive and respectful approach to sexuality and sexual relationship, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So what is sexual dysfunction? When we say sexual dysfunction, it is defined as disturbances in sexual desire and in the psychophysiological changes that characterize the sexual response cycle and cause marked distress and interpersonal difficulty. To say that they are having sexual dysfunction, they should have distress may be there for over a period, definition say they over a period of 6 months, and they have interpersonal difficulty, which causes interpersonal difficulty. We call it, as coined the term, sexual dysfunction. And female sexual dysfunction is a highly prevalent and often underestimated problem in the general community. Infertility causes around, in 15% of the couple have difficulty in becoming pregnancy, and about 40% the causes are in the female. And a study has told about 43% of the women experience sexual dysfunction and 12% with both sexual problem and associated distress. In men, around 31% have sexual dysfunction. That is a study which says. So what happens is sexual problems may be causing infertility, and infertility may be causing sexual problems, and both can coexist. So sexual dysfunction may be a cause or a consequence of infertility, and infertility may exacerbate. Already some amount of sexual dysfunction will be there, and infertility exacerbates the already present sexual dysfunction. So when a couple is seen in an infertility clinic, it is almost about, say, 1 year after trying and failing to become pregnant. With each unsuccessful month, leaves them with a greater sense of concern, anxiety, guilt, blame, or anger, and not becoming pregnant. And apart from that, when they're not able to have children, the effects of infertility leads on to marital disharmony. It's a ground for divorce, and even lead to exclusion from the family or community. As infertility continues, feelings of sexual inadequacy and depression can occur, to the emotional, because of the emotional link between sexuality and fertility. So many couples in infertility treatment say they avoid sexual intimacy during the non-fertile period. They confine sex only during the fertile period. So infertility treatment also brings stress and psychological and financial demands to them, and a lot of physically intrusive procedures are done to them, which can affect a person's sexual self-image, desire, and performance. So for many couples, making love is one form of connecting them emotionally. And when they are unable to, when their sexual lives are associated with failure, they lose the way of showing their emotions. So the pressure to perform or to abstain from sex due to infertility treatment pushes the couples even apart. So the physical and emotional disturbance occurs in between them. Fertility treatment makes sex less spontaneous, less enjoyable, and as sex become focused more on baby making, not on love making for sexual pleasure, they go on to have sexual dysfunction. So today, stress is one of the important factors. People are very much stressed due to financial or workplace stress, and when they have, women are having desire stressful, they have decreased desire to have sex, and they find difficult to become aroused and to have orgasm. So couples who are infertile and are participating in IVF and other infertility treatment, they have a decrease in desire associated with stress of having to perform the act. So there are various classifications of sexual dysfunction. One is an American Foundation of Urological Diseases. They can divide into hyperactive sexual desire disorder, sexual aversion disorder, orgasmic disorders, and sexual pain disorders. And international classification, they have included sexual arousal disorders along with it. But now the DSM classification 4, which has been now from, the latest classification, the DSM-5 classification in 2013, they have included 3 things: sexual interest or arousal disorder, which has combined hyperactive sexual desire disorder and sexual arousal disorders, orgasmic disorders, and genitopelvic pain or penetration disorder. The genitopelvic pain or penetration disorder includes vaginismus and dyspareunia. Sexual aversion disorder is deleted. See, all these disorders are subtyped as lifelong or acquired or generalized or situational. So sexual function dysfunction, the problems in any phase of the sexual response, either in desire, arousal, orgasm, or resolution, as well as pain disorders, may contribute to infertility. It affects as many as 30% of men and 40% of women. For couples dealing with infertility, it is even more common. So psychosexual problems can masquerade as case of infertility, or in infertility, it may be an incidental finding of sexual dysfunction. So either way, you can have sexual dysfunction. And the impact on males are mainly because they have a low self-esteem because of the demand. I mean, they have been asked to have demand sex or schedule sex, higher anxiety, more of somatic symptoms. They have great feeling of greater sexual inadequacy. This has a negative effect on erectile function. And male sexual dysfunction occurs mainly because, sexual intercourse becomes obligatory, repetitive, and routine with less emotional rewards and little excitement. So they have developed performance anxiety, sexual avoidance, and even aversion to sex. The scheduled sex, pressure to perform on demand, and the couple pressure to conceive, and they feel that they have something, medical team is in the bedroom, and that they have a sexual difference. So planned sex and extensive painful tests, intense feeling of anxiety, all are causing for sexual impairment. So what is psychogenic infertility? Many times, some in women, these are not, sexual functioning and infertility have not been a subject of scientific study until recently. Psychogenic infertility may be due to unconscious fear of pregnancy, history of frigidity, childhood timidity, unsocial behavior, poor psychosocial development, rejection by her mother, or hatred by during development. During her childhood, they may not had a good happy childhood, fear that if she becomes pregnant, she may injure her child. All this will lead on to psychogenic infertility. So as gynecologists, what is our role? Gynecologists should be aware of the relation between infertility and sexual dysfunction. Sexual dysfunction common in infertile couple, and taking sexual history before, during, and after treatment of infertility is essential.
So sexual dysfunction causing infertility can be successfully treated if you have looked into it. So saving time, effort, and money for the investigation and treatment of infertility. And we have to educating the couple on the impact of treatment on their sexual function and asking them to seek help if symptoms develop should be their priority. So there are various other causes of sexual dysfunction like vascular insufficiency, diabetic neuropathy, sexual dysfunction due to changes in hormone levels. But for the diagnosis of sexual dysfunction, a detailed history should be taken initially, followed by a physical examination. So the main screening sexual history, the two histories questions are very much important. Are you sexually active? Do you have any sexual difficulties? 16% of the non-complaining females have sexual dysfunction. So if a gynecologist says that I do not see female sexual dysfunction in my clinic, it means either she's not looking hard for it or she's avoiding the topic altogether because of our own self infection, inhibition. So what is comprehensive sexual history? Generally, you should ask them, does she and her husband have similar levels of sexual interest? How frequently they have sexual intercourse? Are they satisfied with the current frequency of sexual activity? Do they have any difficulty becoming sexually aroused? Whether she has any difficulty in becoming sexually aroused, whether her husband is having difficulty in becoming sexually aroused, do they have problems reaching orgasm? Is intercourse painful? These comprehensive sexual history and basic screening sexual history, as a gynecologist, we should be able to ask them and not think that they are superfluous, and we should be asking this history. So once we ask, we will be able to know what are the type of male sexual dysfunction, whether loss of desire, erectile problems, premature ejaculation, or regular ejaculation. And these problems may be transitory also. Men can have transitory impotence or transitory ejaculatory failure. For some men, when they have one or two failures during sexual intercourse, a vicious cycle or fear of failure, the anxiety may lead to further failure. Types of female sexual dysfunction are loss of sexual desire, vaginismus, and dyspareunia, and orgasm. Orgasm is not essential for conception. We say in rape cases, they become pregnant, but it improves its chances slightly because it stimulates the cervical and tubal activity and stimulates the secretion, which is favorable for the migration of spermatozoa. So what types of sexual dysfunction, both can have diminished sexual desire, decreased sexual activity during non-fatal periods. Intercourse may be, they avoid intercourse because it reminds them of fertility problem, arousal difficulty. All this can occur in both the partners. So the sexual dysfunction can be generalized or it may be situational. Situational may be limited to certain situations or to the partners alone. So in infertility, they may have occasional periovulatory orgasm dysfunction can occur, periovulatory impotence can occur, periovulatory retarded ejaculation, decreased frequency in the luteal phase, change, who is the person, which partner is initiating sexual activity. All this can have because of the infertility. To summarize, sexual dysfunction can affect anyone at any time, but is especially common in couples struggling with infertility. It's important for couples undergoing treatment for infertility to be aware that some type of sexual dysfunction is common. Being willing to accept support when it is needed can help couples keep the intimacy of their relationship during this challenging time. So sexual pain disorders include both vaginismus and dyspareunia. The type of sexual pain may be intrauterine pain, mid-vaginal pain, deep vaginal pain. It could be a pain before intercourse, just like a phobic attitude towards penetration, pain during intercourse, or pain after intercourse. So whenever they have a sexual pain, that acts as a vicious circle, and because of that pain, muscle spasm, again anxiety, distress, avoidance of intercourse, and they go for infertility. So whenever a person comes with a sexual pain, we should be able to treat them. Actually, we should be asking a detailed history. It needs multidisciplinary approach so that they are when the pain is taken care of and they become pregnant. So the management of sexual dysfunction in men, women, and couple are interrelated, and the management includes proper counseling. The gynecologist should ask about sexual functioning and satisfaction. We should watch for signs of marital conflict and disturbance. One should encourage couple to become educated about normal sexual functioning and activity and the sexual problems and infertility. You should recommend against ritualist, mechanistic procuration approaches to sex, suggest some planning sexual activity that are not for procreation only. So you have to give tips to the couples, ask them to have relationship as a couple, not as parents to be. So if they are thinking that you are going to have a child and always thinking about baby making, they will have sexual problems. So ask them to face sexual challenges as partners, and ask them to do it anyway, because sex encourages intimacy. Make time for love making, not for baby making, and ask them to say that infertility does not define themselves. They should be able to seek help whenever they seek help, and know that they are not alone. And advise them not to sacrifice rewarding sexual encounters, intimacy for infertility treatment. So now what is our dilemma as a physician? Many a times people are not willing to talk about sexual problems. They don't want any treatment. They want the baby out. So sexual problems may mask more severe psychological or marital problems. At the same time, additional medical treatment may strain them, individual or couple functioning. So should medical treatment for infertility proceed unchecked even when patients refuse psychological or sexual treatment? We as physicians should always think, although some patients may proceed with infertility treatment in the presence of sexual dysfunction, medical treatment should be in conjunction with psychotherapy or sex therapy, emphasizing the importance of sexual health and well-being in infertile couples. Whether sexual dysfunction is a pre-existing condition or an unwelcome side effect of infertility, infertility treatment, it can be a devastating and discouraging blow, compounding the disappointment of childlessness and the distress of medical treatment. So the take-home message is healthy sexuality is central to psychological well-being and quality of life. Infertility has been described as a stressor and a life crisis for individuals or couples, which results in a lower quality of life and marital conflicts. Many infertile subjects experience struggle in various aspects of sexuality. Infertility affects self-concept and role perception and is a threat to personal identity. So for infertile women, the negative impact on self-esteem has a greater impact on sexual confidence. They should be given, as gynecology, we should be given them a careful consideration as a part of a holistic approach to case management. It is therefore necessary to understand and address this psychosocial sexual issue. I think with this, I just conclude my session. Thank you, everybody, for the patient listening. Thank you.
Thank you, Madam Premlata, Madam. That was an excellent talk on infertility and sexuality. See, as we all know that India has a long way to go about discussing these problems in a very open way. But when it comes to infertility, definitely a history of proper sexual function is most necessary to aid the infertility. So here, whatever points you had said has really would have reached home to all the delegates who are watching this. And again, since couple are actually we are getting more and more of elderly couple coming to us for infertility treatment. The regenerating the sex life after 40 also gains a lot of importance. And again, Dr. Neeraj had given an excellent talk on this topic. And thank you for the excellent talk that you have given.
Thank you, Chairperson. Madam, yes, ma'am.
Okay. Can I just have I just want to add a small thing. Is it important to educate all these young girls? Because I see many people coming with severe vaginismus. They're just newly married. They've not even consummated their marriage 1 or 2 years. And then all that they have is the fear of penetration. So much there. So once you teach them and then you just counsel them, within the next 2 or 3 months they've conceived. So is it important that there should be some sort of a sex education or something like that before they get married?
Yes, madam. Definitely.
Because I always wondered, how was it that we are doctors, we know, and then we've read, and then we know, but how do these people who are uneducated, how do they know? But that was always my, how do they know? We have many people come from, how do they know how to go about everything, and then they get pregnant immediately? What really clicks in them?
Ma'am, I just want to add up 3 points here. One is, as you rightly said, premarital counseling is mandatory for many women. And if you see in many religion, they have a counseling. So there are good and bad about it. So if you take the Orthodox Catholic group of people, they have a special session for the couple to be getting married with some counseling aspects which involves the sexual acts, about the sexual life, their intimacy, their nourishment of as a couple together. They do some counseling. And secondly, in the olden days, if you go through the history, there are a lot of education by the parents, by the elders in the family, but that has a good effect and bad effect. But sometimes, because they say it's painful, so automatically some women develop a phobia for that. So that also is one important point we have to consider. And thirdly, all our technology, all the Google, everything gives a very wrong notion of the painful sex for the virgins. So these are all something that we have to address as a public forum. As I think Neeraj and we were all talking all these things. We will be definitely planning to have some. Yesterday also,
Especially when
was telling,
college girls, I think they should know
we have
about
to
it.
do some educating programs, and definitely that will help them to tide over this problem to get them in a better way.
So we really
Madam,
enjoyed this
sex
session.
education in the school is very difficult to convince the school authority as well as parents to go about the sex education in the school. There is a
But college,
Yeah.
final year, I think they should
even
know a
in
little
college,
bit about that.
it's not easy in some metro cities. It is okay, but in smaller cities and small town, it's very difficult to convince the authority to go about this type of education. We have to mix with the other health education and give some sort of sex education. We can't directly tell them that it's about the sex education. We have to mix with other things and give them education.
Exactly, Dr. Neeraj. Sampath Mari also must be knowing when we conduct this adolescent education. At that time, we are talking about anemia and other things. At that time, there is discussion about this sex education also. In that areas, we used to explain to them and we encourage them to come out with more questions and we clear them. Isn't it?
Only one point I'll encourage. Jairani, with your permission.
Yes, welcome.
Chitra madam, you are very, very innocent, I think. When you go to the school counseling, the girls will ask
No, there are two
questions.
That's what
How many times I can use the easy pills in a month? Yes, so these are all the questions.
Madam, now, I think Coimbatore is not so bad.
No. Whether it is Coimbatore or
you haven't gone to the society, ma'am. You haven't gone to the society, ma'am.
No,
madam.
Are
very much aware.
One thing, as far as sex is concerned, whether rural or urban or rich or poor, everything it is the same. The adolescents, they know, but they don't know how to, whom to tell and how to tell. That's all. We think that we should not talk to them. But rather than learning from the media, it is better the parents should teach the adolescent. What is, previously we used to tell good touch, bad touch. Nowadays it is not good touch, bad touch. Which is what to tell, how to behave. Everything is important, madam. So now most of the some girls are there, but still we are giving even the, we don't tell a sexual health, reproductive health education. That's all, Chitra madam. Most people, some people, they come to the OP itself. I am living with my boyfriend. How can I prevent pregnancy? There are
that extreme is also there, but this extreme also exists.
Thank you, madam. Thank you, Jairani.
Yeah. So thank you, chairpersons, and thank you, Madam Dr. Chitra, for the nice coordinating this session. And I thank all the chairpersons, Dr. Umayal, Dr. Mary Genova, Madam, and Dr. Chandra, Madam, for your excellent chairing the sessions, which made it very lively. And I thank all the chief guest of honors here for their active participation to encourage us. Thank you. Now we are moving on to the second session. I have the great pleasure and honor in introducing the coordinator of the second session, Dr. Sumati, who is a best friend of mine, my classmate, and we did a MD together. And she's presently the HOD of Madurai Medical College, OBGYN department, and she's the present president of MOGS, that is Madurai Obstetric Gynec Society. And she has got a lot of medals in her college studies, and she has published a lot of articles in her national journals, and she was a chairperson in many of the national and international conferences, and she has got the best doctor award from the government of Tamil Nadu in 2019. Over to you, Sumati, for coordinating the second session.
Good evening, Jairani. At the outset, I would like to thank Dr. Jairani for convener, and also Dr. Neeraj, the chairperson of the Sexual Committee, for this opportunity. And really congratulations, Dr. Jairani, for organizing such a good webinar that is the focus on female sexuality. and my best wishes to you also. And in this session, we had two topics. That is, one is management of the male erectile dysfunction, and another is sex and sexuality in pregnancy. And I invite the chairpersons, Dr. Vidya Prabhakar. She's the president of OG Society Salem and ART training at Singapore she had, and she is the senior IVF consultant Salem and organizing secretary for ART Con as well as ACOG. And welcome Vidya Prabhakar madam. And I welcome Dr. Radha Madhavi. She is the founder president of Tiruvannamalai OG Society as well as director Raja Multi Speciality Hospital. And she had practicing the gynecologist since 1994 till date and conducted annual conference at Tiruvannamalai. And next is Dr. Shanti Rani. Shanti Rani is also, she did UG at Tirunelveli Medical College. She is my senior and now she's the associate professor at TENI, and she's the founder, treasurer, secretary of TENI Society and now the president of TENI Society, and organized so many workshops and Eagle Project at TENI, and organizing joint secretary also in Endocrine TENI, that is in 2017, and awarded Best Doctor by IMA TENI branch, as well as faculty in ACOG in 2018, 19, 20. And welcome Dr. Shanti Rani. And over to Dr. Vidya Prabhakar. I'm handing over the session.
Sorry to interrupt the session. Dr. Vidya Prabhakar has held up in a sudden emergency. So I would request Dr. Radha Madhavi and Dr. Shanti Rani to take over the proceedings of the second session.
Okay, ma'am.
Good evening, everybody. It is going on very well. End of this thing, we'll have a good discussion.
Somebody introduce the speaker.
Of Narayan Reddy, please.
Shafi sir. Shanti ma'am, you all introduce.
Yeah, he has to share. Good evening, everybody. It's a great privilege to introduce Dr. Narayana Reddy sir. He is a certified supervisor of sex therapy of American Association of Sexuality Education and Therapies. He is a course coordinator and faculty of College of General Practitioners of Indian Medical Association. And he had various official positions. He's a president. And he had got many awards, Distinguished Fellow Award in American University and Lifetime Achievement Gold Medal Award in World Association of Sexual Health, and Lifetime Achievement Award in 2012 by the Tamil Nadu Dr. MGR Medical University, and Lifetime Achievement Award 2013 for Council of Sex Education and Parenthood. And over to you, sir.
Thank you, respected chairpersons. The topic given to me is management of sexual problems. Can you hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Since the time given to me is only 15 minutes, I am forced to rush through my slides. Kindly bear with me. And may I request the event manager to start presenting my slides? Shafi?
Shafi?
Yes, doctor.
You have his slides, sir? Slides, no?
No, I don't have his slides.
Oh my God. I will just, sir.
Yeah,
sorry,
please,
I have it. I have it. I will project. I thought you have it. Okay, fine.
You can make Madam as a co-host. I think Madam can share the slides.
Yes, yes. Doctor, you can only share it from your...
yeah, I'll do that. I'll do that.
Yeah.
Is it visible, Shashi?
Yeah, you can click on the
Yeah. Yes.
attachment.
Yes, sir. Can you see, sir?
No, madam, you're not able to see.
Okay.
You have to download first it.
Oh, I downloaded it. I downloaded it, and from there only I'm projecting it.
You are doing it from the mail.
Download the attachment.
Okay, I downloaded it.
You have to first the download.
Fine.
Or we can finish the next lecture and then come back to first.
1 minute, sir. I have downloaded it. It is only from the downloading only. I just.
No, doctor, you can forward it to me. I'll flash it from my system.
Now, can you see that?
No, we are not.
Not it.
I think we let us finish next lecture and then come back to this one.
No, I'll forward it.
Yeah. Meanwhile, we can finish the next lecture.
Yes.
Okay. So I think, Madam, you can introduce. Sorry, sir. Extremely sorry. Padmini, you can introduce Dr. Padmini, Madam.
Can I have that? It's a great privilege to introduce Dr. Padmini Prasad. He's a consultant obstetrician and gynecologist and sexologist and marriage counselor of Ramamani Nursing and Maternity Home and Padmini Clinic. She's first qualified woman in sexology from Karnataka, and she is the medical director of Ramamani Nursing and Maternity Home Institute of Sexual Medicine of Bangalore, and is the president of Bangalore Society of Obstetric and Gynecology, chairperson of Sexual Medicine and STD Committee of KSOGA, and he is a committee member of Sexuality Education and International Society for Sexual Medicine. He's a national coordinator for Sexual Medicine Committee, FOXY, and secretary and vice president of Bangalore Society of Obstetrics and Gynecology. He's a former vice president of Family Planning Association of India. He's a gold medalist of MD Obstetrics and Gynecology and recipient of numerous awards. And she is the author of 11 books on sexual and reproductive health in Kannada and English. Welcome you, and over to you, ma'am.
Okay. Good evening to you all. Thank you very much for that kind introduction. It's a great learning experience to meet such stalwarts from Tamil Nadu societies. Thank you, Dr. Neeraj Jadhav. Thank you, Dr. Jairani, for this opportunity to be with you all this evening. I will share the screen. Greetings from Karnataka. Sex during pregnancy, sex and sexuality. Sex during pregnancy is a frequently misunderstood aspect of pregnancy. Unless physicians are familiar with scientific data in the area, the potential for providing patients with misleading and incorrect information is great. Fear of abortion, infection, low energy are the reasons to forbid coitus during pregnancy. Animals do not copulate during pregnancy, which we have to know. Obstetricians and healthcare providers should take more active role in counseling about intercourse during pregnancy and postpartum. I can just give you one or two examples how we meet people. Recently, I met one of my patients that was a very loving couple and love marriage, and she came to me crying one day. Then I asked her, what is it? You are such a loving husband. You have such a nice family. She said, during pregnancy, we never had any intercourse. And after the delivery, I stayed in my mother's place for nearly 1 year. There was abstinence for a long period. After I came back home, I just came to know that my husband is having a relationship with the maid servant. I just don't know what to do. And another patient, frequently she was coming and getting admitted for antepartum hemorrhage, bleeding during pregnancy around 7th month. And each time we found out nothing in her which could cause bleeding. We treated her and sent her back. And when she got admitted 3rd or 4th time, When I was taking a detailed history, I just asked her about the sexual history. She told me, please, madam, keep me in the hospital. My husband wouldn't leave me. So till delivery, I would like to get admitted in the hospital. The another patient came with a premature rupture of membranes, and she had a cervical stitch. She never had received any advice regarding intercourse during pregnancy. Another couple came and asked me after 2 years after delivery, doctor, can we have intercourse now? My child is 2 years old. So there is lot of ignorance, lot of questions, lot of worries, anxiety about sex during pregnancy, both with the patients and also the healthcare providers. Women's sexual function is a complex interplay of physical, emotional, and psychological factors between the couple or partners. Pregnancy is a very natural phase in a woman's life. Both pregnancy and sexuality are natural and normal phenomena of a woman's life. To be a mother is a natural instinct of every woman. Pregnancy or childbirth is not a disease. The couple need not be denied of sexual pleasure and happiness when pregnancy is devoid of any complications. Sexual relationship is part of quality of life. The woman and the couple will have plenty of questions regarding sexual activity during pregnancy. They feel shy and are hesitant to discuss the issue with their doctor. Doctors also think that it is not an issue to discuss. Changes in sexuality can be significant during pregnancy and in the postpartum period. Unless physicians are familiar with scientific data, so you tend to give misleading or incorrect information to a great extent. Patient may rely on anecdotes, old wives' tales, or other incorrect sources. When the woman conceives and welcomes her new bundle of joy, the whole family will be preparing to welcome the new member. The woman starts getting many advices regarding diet, sleep, dress, travel, etc. Everyone is willing to give some advice or the other to the woman, the mother to be. The only advice she is not getting is about the sexual relationship. Sexual behavior depends on age, culture, relationship, physical changes, discomfort, fear of fetal damage, partner's sexual function. During pregnancy, there are various hormones which have an effect on physical and mental changes that can have an impact on sexual functioning. Progesterone, responsible for physical and mental changes in pregnancy, can have an impact on sexual functioning. Estrogen can affect sexual desire and function. Oxytocin, which releases during orgasm, can cause uterine contractions. The prolactin, which is a high level prolactin, the increased level can affect sexual desire. There are psychological changes like decreased self-esteem, anxiety, fear, body image, perceived loss of attractiveness, cultural differences, myths about sexual practice, and interpersonal relationship. The physical aspects of sexuality in pregnancy, I need not tell you, are all gynecologists, like nausea, vomiting, urinary frequency, urgency, breast changes, genital changes, vaginal secretion. All these can cause discomfort and can have a bearing on sexual activity. Healthy sexuality is essential for good quality of life. Sexual activity, even during pregnancy, is essential for self-esteem, couple relationship, and well-beingness. To be a mother or to advise abstinence throughout the period of pregnancy, doctors, to be on the safer side, it is better to have abstinence throughout the pregnancy. After delivery, a woman normally stays in a mother's place in most of our places for nearly 6 to 12 months. The side effect, as I was describing in one particular case, the side effect of abstinence for a longer period is either disturbed interpersonal relationship or extramarital relationship of the husband. Every couple has plenty of questions regarding sexual relationship. Because of the taboo attached to sex, many couples do not consult the doctor. So these are the various questions. Is sex during pregnancy safe? When it is not safe? Can sex harm the baby? Can intercourse orgasm cause abortion or uterine contractions? Is sex drive increased or decreased during pregnancy? The man's view. Hence, doctors should be aware of all these things, sexuality concerns during pregnancy to answer the questions of the couple. Most pregnant women can engage in sexual activity throughout pregnancy in the absence of any complications. The sexual desire, libido, arousal, orgasm vary during the 3 trimesters. Couples should keep some level of intimacy going on. Most researchers suggest sexual desire during first trimester of pregnancy decreases. Some studies indicate that it increases during second trimester. Some women report greater sexual satisfaction during pregnancy. Sex during pregnancy is a low risk behavior, except when it is a high risk pregnancy or there is a bad obstetric history. Psychological usefulness of having normal sexual life. Some research studies in 1980s and 90s indicate that overall sexual satisfaction was correlated with feeling happy about being pregnant, feeling more attractive in late pregnancy, and experiencing orgasm. The natural prostaglandin content of seminal fluid can favor the maturation process of cervix, make it more flexible, allowing easier dilatation and effacement of cervix. There is some evidence that exposure to partner's semen prevents PET due to the absorption of several immune modulating factors present in the seminal fluid. During pregnancy, the fetus is protected from penetrative thrusting by the amniotic fluid and by the cervix. The thick mucus plug that seals the cervix helps guard against infection. While orgasm may cause mild uterine contractions, also the nipple stimulation and prostaglandin semen can cause contractions. They are temporary and harmless. Will sex be different during pregnancy? Many report that sex feels different during pregnancy. Some find it more pleasurable, others feel it less pleasurable. So increased blood flow to the pelvic area can cause engorgement of the genitals. The heightened sensation that results may add to the pleasure during sex. More vaginal discharge or moistness will also help as lubricant. For some, the genital engorgement may give uncomfortable feeling of fullness. There can be mild abdominal cramps due to uterine contractions after orgasm. The breast may feel tender and unusually sensitive to touch, particularly in first trimester. Breast remains more sensitive throughout, but some women may prefer that the breast stimulation is not done at all. The partner should know if anything feels uncomfortable. If the woman is not enjoying intercourse, the couple can indulge in mutual pleasuring, hugging, kissing, oral sex, or self-stimulation. So they have to experiment and adjust according to the situation. Libido can return in the second trimester after morning sickness and fatigue have eased up. The desire can wane in the third trimester, particularly in the last month of pregnancy. She may be too big or exhausted to make love. She may feel self-conscious about her body. She may be preoccupied with the approach of labor and birth of the child. She has to reassure her husband that she continues to love him. The orgasmic function. The reduction of orgasm is noted in some studies. Clitoral sensation may reduce during pregnancy. Non-coital behavior like masturbation, hugging, kissing can continue. Women likes close physical contact. According to Masters and Johnson, sexual behavior of pregnant women remains unchanged or decreased during first trimester with improved sexual function during second trimester and again a decrease during third trimester. So similar studies found out by the Bancroft. The couple should keep the lines of communication open. Will sex harm the baby is a common question which is there in the mind of the husband or the mother. The baby does not get hurt by making love. The thick mucus plug guards against infection. Amniotic fluid and strong muscles of uterus will protect the baby. With orgasm, baby may move around more. This is because of increased heartbeat of the mother and the uterine contraction. When sex during pregnancy should be avoided. This I need not elaborate because all gynecologists know about all high-risk pregnancies when the intercourse can be avoided. Is it normal if there is no sex during pregnancy? This is also so many times when we advise in high-risk pregnancies that you should not have intercourse. So they will ask me because their parent, my mother told me that you must have sexual intercourse. Otherwise, you will not have normal delivery. So there are some people, they are also worried if they don't have intercourse, what will happen? Yes, it is normal. Pregnancy hormones can reduce libido. If one feels positive about the pregnancy and the associated changes, one can feel more sexual. If the woman is unhappy or feels insecure or have relationship problems, it can have negative effect. What is normal for one person need not be normal for the other. What is the partner's or dad to be the behavior? Man can feel as attracted as usual during the first and second trimesters. He may feel less interested in the third trimester. Reasons for lack of desire for the dad to be: fears that sex can hurt the baby, worries about the wife's and unborn baby's health, apprehension about burden of parenthood, self-consciousness about making love in the presence of the unborn child. Doctors should discuss the fears and concerns with the dad-to-be and reassure and advise him. So the couple should be advised about what is right, what is wrong, when they can have, when they have to avoid. Is oral sex safe during pregnancy? Yes. Normal oral sex won't harm the baby. Avoid blowing of air into the vagina. This can cause air embolism and can be fatal. Sometimes just licking and kissing activities can be maintained. Sexual positions which are comfortable during pregnancy. As the pregnancy progresses, the missionary position is not comfortable anymore. Woman on top gives more satisfaction. Lying sideways will also help. It avoids deeper thrusting. Coming to the edge of the bed with the partner standing or kneeling in front. Lying side by side in spoon position. Doggy position. Making love sitting on the partner's lap. In any position, the pressure on the abdomen and deep penetration inside the vagina should be avoided. With a little experiment, couple can find out what is correct, what is right, and what will give them more pleasure. The various sexual dysfunctions which can occur during pregnancy. And female, as usual, there can be decreased libido, there can be anorgasmia, and there can be dyspareunia in some, especially if there are infections, genital infections, itching, irritation. You have to treat the infections and then allow them to have sexual relationship. Similarly, the man can have decreased libido, premature ejaculation, and even erectile dysfunction. Expected or presumed complications of coitus, because many people are worried whether there is prematurity, whether there is fetal distress because of the sexual relationship. Studies show no relationship to PROM, premature labor, low birth weight fetus. Fetal distress, no association of orgasmic uterine contractions, prostaglandins in semen, STD have not caused any labor or fetal distress. Vaginal bleeding. Sometimes if the cervix is very soft, deep thrusting can cause little bleeding. Postcoital bleeding can occur unless there is some contraindication like placenta previa and some other conditions. Infection. Only in women with trichomonas vaginalis, bacterial vaginosis, mycoplasma infection, there will be increased risk of preterm labor. Otherwise, there will be natural protection. So coming to making love after birth, this is about during pregnancy. Similarly, they have a lot of questions after delivery, and this has to be advised when they can start the intercourse, when they can resume the sexual relationship after delivery also. You really have to wait. How long they have to wait? The mode of childbirth, whether it affects sexual life, whether it's a natural birth, cesarean section, episiotomy, whether it is assisted delivery, forceps or vacuum. What are the men's concerns? Earlier, they used to put an extra knot to tighten the vagina, which was known as husband's knot. When is it safe to have sex after the birth of the child? Wait until the bleeding stops completely and wounds have healed. Normal involution of genital tract has occurred. One is physically and emotionally ready for sex. Then use of contraceptives is a must when you are advising sexual relationship. Small number of couples have sex within the first month after delivery. Many wait until 6 weeks. Most couples try sex by 3 months. Even in most of the religions, we always see there is a ritual made on 40th day or after 6 weeks that they can stay together and they can start the intercourse, going to the temple, starting the relationship. So that's how it is kept, because at least it takes 6 weeks. for the normal involution to occur and the wounds to get healed. Most studies advise to start sex 6 to 8 weeks after delivery, either normal, cesarean, or instrumental. If one is not yet ready to have sex, the other has to continue with foreplay by being physically close to each other. Lack of sex desire after delivery can be that mother feeling exhausted, lack of sleep, demands of motherhood, high prolactin hormone, low estrogen, feeling low, postnatal depression, fear of pain, and stress. Post cesarean is like recovering from a major operation. So, self help tips. Try just cuddling and being intimate at first. Gradually get used to being sexually aroused. Enjoy each other's company with plenty of foreplay without expecting it to lead to penetrative sex. Try lubricating gel. Try making love during baby's nap time. Keep doing pelvic floor exercises to bring back muscle tone to vagina. So after delivery, important questions to be discussed with the patient is when they can start sexual relationship, how they can do Kegel's exercise to get back the muscle tone of the vagina and the pelvic floor muscles, and the contraceptives. This should, because most of the time they may be giving the contraceptive advice, but along with that, this advice is extremely important. If there is persistent dyspareunia, call the doctor and get help. So many times we have seen such painful episiotomy scars and other scars which are there, and they will be continuously complaining. They will be having dyspareunia even after 1 year, 2 years, but they will never complain. Only when you are doing a pelvic examination for some reason, then they will tell. So we are not having proper intercourse because I get very severe pain. Eat well, drink plenty of fluids, and rest whenever you can. The common advice to the mother. To have sufficient energy left with, she needs to look after herself. To look after herself in all possible ways, whether it is food, sleep, energy, exercise, she has to look after herself. More focused research is needed regarding sexuality during pregnancy and childbirth. Most patients welcome the freedom to discuss the topic. Practical advice as a part of prenatal care should be a routine. So if there are any questions, tell them, ask your doctor for any query or problem regarding sex during pregnancy. Thank you very much for your patient here. Thank you very much.
It was an excellent talk, madam, because you have almost cleared the usual questions that is asked by the women during the pregnancy as well as in the after delivery. So almost you have cleared everything. It was so nice, and really it is good, madam.
Madam, it was an excellent talk, and I wonder how you are able to talk freely about so many aspects with the pregnant mother and after delivery. Will the men in Karnataka accept all the answers you give them and all the advice you give them? Because I find men here not accepting half the things I tell them.
No, because people know me that I deal with sexual dysfunction. I treat both men and women about their sexual dysfunctions because I give a lot of programs in televisions and write in the news and magazines. So they know that I treat it. They are all very comfortable talking about all these things.
It was nice, madam, and I hope we can also speak freely. In
You
our
have to become
OP.
comfortable with your own sexuality. That is the first thing. Whenever you want to talk about sexual thing, be very comfortable. Talk straight to the person. See with the eye to eye contact. Keep it maintain and be comfortable with your body language.
Abstinence is one thing we can never avoid in these rural areas. So will it be easier if we advise them to have sex with condoms?
Yeah, because if it is a problem for them, see any of these sexual dysfunctions, the dictum is that if they have
prevent infection.
No, if it is causing any frustration or problem to the person and to the partner, if both of them don't have any problem with it, leave them alone. So if they complain, or you can just talk to them. If there is any problem with your sexual relationship? Is your husband interested? How she can cooperate? How they can maintain the relationship? So husband will be too willing to talk about it when you really open up the topic.
Thank you, ma'am. Thank you so much.
I'm happy that Dr. Narayan Reddy I'm meeting here also. Good evening, Dr. Narayan Reddy.
Thank you, Padmini. That was an excellent talk, as usual.
Oh, thank you, sir.
Friends from Oxy and Foxy, I've been asked to speak on the management of erectile dysfunction. Next slide, please. The fundamental and basic principle of the management of ED is if it is due to organogenic factors, we institute appropriate medical or surgical treatment. But I would always recommend add some amount of counseling because the sexual response is psychosomatic in nature. Now, some amount of anxiety will be there. So you have to relieve that anxiety. So add on counseling. If it is due to psychogenic factors, then you offer them education or counseling, and in some cases, sex therapy. Always think about the relationship factor, which Dr. Padmini and others have been talking about. And if there is a marital discord, you must also undertake concurrent marital therapy, if not by yourself, by referring to a competent marital therapist. And wherever necessary, you require, no, please don't go. And wherever there is necessary, add psychotherapy and psychoactive medication. Now for this talk, I am not going into purely psychogenic because counseling and therapy is going to take a lot of time and our time is restricted here. I would rather go the way in which sexual medicine is being practiced by medical fraternity at large. Next slide, please. Now the modalities are your first line, second line, and third line. In the first line, oral drug therapy, always add counseling and advise lifestyle measurements. In the second line of therapy, introduce intracavernosal injections, vacuum suction devices, and medicated urethral suppository of prostaglandin even. Again, here also add counseling and advise lifestyle measures. In the final and last stage of management, resort to penile prosthetic surgery. Again, that also requires counseling and requires lifestyle measurements. Next slide, please. Now, a bit about oral pharmacotherapy, which today you find most pharma companies are coming up with. Next slide. What we call PDE5 inhibitors. There are 11 families of phosphodiesterase in our body. Each has got a specific function. Whereas phosphodiesterase type 5 for specific action in the cavernosal tissues and spaces. That is why we call them PDE5 inhibitors, the drugs which inhibit the action of PDE5. Now, currently available in the world is sildenafil, tadalafil, sildenafil, vardenafil, myrodinafil, avanafil stendra, iodinafil, myrodinafil, zeparnast, icarian, benzamidactyl. Now, these are the available PDE5 inhibitors for the treatment across the globe. Next slide, please. Among these, the first four only are available in India. That is sildenafil, tadalafil, sildenafil, and vardenafil. Sildenafil is a Korean product for inflammation and is quite effective. Now, avanafil or stendra is available in the US and European countries, not in India. Next slide, please. The strength in which they are available in India are sildenafil 25 mg, 50 mg, and 100 mg. Tadalafil 2.5 mg, 5 mg, 10 mg, 20 mg. Sildenafil 100 mg and 200 mg. Vardenafil, the latest entrant to India, it comes in 10 and 20 milligram strengths. Next slide, please. Now, what are the pharmacodynamics of PDE5 inhibitors? Next slide. Sexual arousal induces the release of nitric oxide in the cavernosal tissues. The nitric oxide stimulates enzyme guanylate cyclase to convert cavernosal guanosine triphosphate into cyclic GMP or monophosphate. It is the cyclic GMP which has got a relaxatory effect on the cavernosal smooth muscles. When the cavernosal smooth muscles are relaxed, we are allowing in pulling up in blood, allowing better quality erection, and allowing continuation of the erection. Unfortunately, in our system, we have check and counter check. So the moment cyclic GMP appears in the system, the body also releases what is known as phosphodiesterase type 5, which is specific to cavernosal tissues. That catabolizes cyclic GMP into inactive 5-GMP. So the action of cyclic GMP is short-lived. So the smooth muscle relaxation is short-lived. And that is what is going to affect the human being. Because we find many times people come and complain to you, we get an erection, but it is not sufficient for me to achieve penetration. Now, when you give any of these medicines like sildenafil, tadalafil, vardenafil, sildenafil, etc., you block the action of the phosphodiesterase type 5 in the body. And because of that, you allow cyclic GMP to be available in the body for longer duration of smooth muscle relaxation or in the cavernosal tissue. So the erection quality is long-lasting and better. And that is how exactly our tablets for PDE5 inhibitors. Next slide, please. Now I'm giving comparative picture about all the four PDE5 inhibitors available in the Indian market. Sildenafil dose I have mentioned already. Onset of action, sildenafil 30 minutes, vardenafil 16 to 25 minutes, tadalafil 45 to 120 minutes, sildenafil 15 to 30 minutes. Duration of action, sildenafil 4 to 5 hours, vardenafil 4 to 5 hours, tadalafil, they say overnight pill, 36 hours, sildenafil 10 to 12 hours. The faster onset of action and the shorter duration of action of vardenafil minimizes the adverse events compared to tadalafil. Now, please remember, if your patient or client is 40 and plus, got comorbidities, please go on for short-acting PDE5 inhibitor like vardenafil or sildenafil. For younger patient with no comorbidity, we can go for tadalafil. The problem with tadalafil is it's got equal affinity for musculoskeletal tissues. So they complain of severe back pain and severe calf muscle pain. And please avoid it for people who got lumbago. Today in the world, because of our sedentary lifestyle, most of us have got a low back problem. So when you give tadalafil, you may increase the pain of the back. Next slide. Now, what are the contraindications for the use of PDE5 inhibitors? Anatomical deformities for the penis, like cardi, Peyronie's disease, etc., hypospadiasis, epispadiasis, etc., any blood dyscrasias, active gastrointestinal ulcerations, unstable angina, or recent myocardial infarction, retinal disorders. Most of us miss them. Please ask them for retinitis pigmentosa, and if they are diabetic, check for any retinal hemorrhages or retinopathies. And the client on nitrate for anginal discomfort. Next slide, please. You have to avoid PDE5 inhibitor if the patient has suffered from myocardial infarction, stroke, or life-threatening arrhythmia within the last 6 months. Avoid in patients with resting hypotension less than 90/50 or hypertension above 170/100. Avoid in patients with unstable angina. Angina comes with sexual intercourse or congestive cardiac failure categorized as New York Heart Association class 2 or greater. Patients taking any form of organic nitrate. Examples are nitroglycerin, isosorbide mononitrate, isosorbide dinitrate, or any nitric oxide donors. Next slide, please. You have to learn to adjust the dosages if the patient is on drugs that inhibit CYP3A4 pathway, because the PDE5 inhibitors are eliminated through CYP3A4 pathway in the liver. Now, the drugs that inhibit this pathway are ketoconazole, ritonavir, atazanavir, clarithromycin, indinavir, itrazanavir, nefazodone, nelfinavir, saquinavir, and telithromycin. These may inhibit the metabolic breakdown of PDE5 inhibitors, thus increasing the PDE5 blood levels. So you require to offer them lower dose of PDE5 inhibitors. Now, there are some drugs which will induce CYP3A4 pathway, like rifamycin used in tuberculosis, phenobarbital, phenytoin, and carbamazine. They may enhance the breakdown of PDE5 inhibitors. So here in these patients, you require higher doses of PDE5 inhibitors. Now be careful in people with severe kidney or hepatic dysfunction, which may require a dosage adjustment or warning as per the condition of the client and the advice of nephrologist and gastroenterologist. Next slide, please. Now, some people may come and complain, doctor, you have prescribed me this medicine, but they are not effective for me. Now, why do PDE5 inhibitors fail? One, severity of erectile dysfunction at presentation, deterioration of endothelial dysfunction. Please remember, today don't use the acronym ED because it may mean anything to anybody. For a urologist, an ED may require think of erectile dysfunction. For a diabetologist and cardiologist, ED may refer to endothelial dysfunction. For a psychiatrist, it may require emotional disturbance. Nutrologists and dietitians, it may require eating disorders. Now, the fact is today, ultimately, whatever is happening due to vascular factors in the vascular tree is due to improper functioning of the endothelium. As we live, every second our body gets oxidized. We breathe in oxygen. With each oxidative episode, our endothelium gets damaged. And that is why you find people are prescribing antioxidant to help endothelial function. People, especially those who smoke, consume alcohol, and who got dyslipidemia, there you have to be very careful about the concurrent endothelial dysfunction. In such patients, even if you prescribe only PDE5 inhibitor, it's not going to be effective. Progressive penile atherosclerosis, post-radical prostatectomy for erectile dysfunction, causing erectile dysfunction, unrecognized hypogonadism, lack of patient education, because we don't educate the patient. I have seen some diabetologists prescribing Butler band of sildenafil citrate and write one at bedtime. Indirectly, they are inferring the patient will have sex only at bedtime. It is not necessary. Patient may have sex anytime. Ideally, it should be advised 1 hour before the act of intercourse if you are using sildenafil or tadalafil. If it is udenafil or vardenafil, you can go up to half an hour to 40 minutes. You have to clearly explain to them. And number 2, they must learn to use it properly. 1, never take these medicines except tadalafil and udenafil on a full stomach and after oily food. And number 2, whatever may be the medication, and even without medication, please advise your clients not to attempt sex on a full stomach immediately after a dinner, hearty dinner. Reason is simple. The body cannot compensate when the food is in the GI tract because more blood has to be pumped into GI tract for digestion. So it cannot compensate by diverting it to pelvic region. So you have to advise the patient accordingly. And most important, the clients who are on PD5 inhibitor must have some stimulation of the penis to get an erection. Just swallowing a tablet and looking at the penis for getting erection is not going to help. You must tell the client, take the tablet, wait for half an hour, 40 minutes or 1 hour. Please start your foreplay by kissing, hugging, caressing a partner. Then only they get stimulation. Improper use of medication. Patients may not wait for the prescribed time. They may take the tablet, within 5 minutes they may start using it. Or they may take the tablet and try for sex after 5 hours or 6 hours. It is not going to be helpful. Psychological issues. If there are psychogenic factors, then even if you prescribe PD5 inhibitors, it is not going to help. One word here when I talk about psychological issues. When you are talking about pharmacotherapy or medical management of erectile dysfunction, we are forgetting the other parties. Whenever there is any sexual dysfunction, remember there are 3 partners: the client, the partner, and the relationship. Unless you manage all the 3 of them, you are not going to get the full result. Otherwise, like what we say jokingly, operation successful, patient died. If you are not going to attach significance and try to manage psychological issues, even prescribing PD5 inhibitor may not be useful. Next slide, please. Now, the second line, you come to vacuum suction constriction devices. Here is a tube, a hollow tube, which can be placed on the flaccid penis. On the patient is holding in his left hand a pump here, through which he pumps and creates a vacuum. The vacuum draws in blood from the main body. Now, when you remove the tube, the blood will go back into the main body. To avoid that, you see here the picture on my right, a elastic band which will compress the base of the penis, retaining the blood in the penis. But this is not very helpful because with this instrument, people only get tumescence, not rigidity. Next slide, please. Then you have the intracavernous injection, which most urologists use. Next slide. There are 3 types of intracavernous injection available. First one is pepaverin, which is usually available in India, or alprastodil, which is prostaglandin even. Or you have Binix, a combination of pepaverin and phentolamine, or pepaverin and chlorpromazine, or a mixture of 3 things: trimix, pepaverin, phentolamine, and alprastodil, or pepaverin, chlorpromazine, alprastodil. Mind you, only alprastodil or prostaglandin even is approved by the US FDA. The other drugs are not approved by US FDA because the chances of producing priapism is greater in other medicines. Next slide, please. When that fails, ultimately you come to penile prosthesis. You have 3 types of penile prosthesis available. One is semi-rigid, second is malleable, third is inflatable. Next slide, please. In semi-rigid, you have these silicone rods. The urologist or the andrologist, specially trained in this prosthetic surgery, opens up the corpora cavernosae. As you know, there are 2 corpora cavernosae on top. Corpora spongiosum, which carries the urethra, is at the bottom. You don't touch that. In the 2 corpora cavernosae, you embed these 2 if possible and close it. So when the patient is there, he has got a sort of semi-permanent erection. So question of erection does not occur in this situation. Next slide, please. Now you have semi-rigid. Here you can bend to certain extent. So when the patient is not having sex, he can bend the penis to certain extent, but not totally. There will be some amount of erection. Next slide, please. What is known as malleable? They are highly flexible. Practically, the patient can make it like a facet penis, and when he wants, he can make it fully erect. Next slide, please. Then you have the inflatable ones. Next slide. Here you have a reservoir which contains a radio opaque fluid and two hollow cylindrical tubes made of silicon, which can be embedded in the corpora cavernosa, and a pump, which can be again, the pump and reservoir can be embedded in the scrotal sac. Next slide, please. In this picture, you can see that picture how it is. Now, when the patient wants or the client wants, he must be trained to press the pump so the radio opaque fluid is pumped into the hollow spaces in the penile implant, so it mimics a natural erection. And after the intercourse is over, he'll be trained to reverse the pump and the fluid gets back into the reservoir. So it's almost like the problem is it's actually extremely expensive. Each with the custom duty in India, it costs you around almost 2.75 or 3 lakhs only the processes alone. Another problem is if there's a mechanical problem, once you embed it, you have to operate that, remove the processes, send it for service to us and get it back, perform another surgery and reimplant. So mostly what India we use is the semi-rigid and malleable, but there are some people, some urologists and some centers in India, they do the inflatable and patients can afford and they are prepared to take the chances. Next slide, please. In a nutshell, I will tell you step by step how you manage when a client comes to you with erectile dysfunction. The first line of therapy is always advise lifestyle modification because most of us may have a metabolic disorder and drug prescription modification because many antihypertensive beta blockers and again anti-androgens and antipsychotics, antidepressants, and anti-epileptics may have problem, produce a negative adverse sexual response. So you learn to modify it or there with the help of the concerned specialist, try to reduce the dose. Advise the patient on quitting smoking or reduce it, avoid using of drugs and alcohol, healthy balanced diet, and most important, regular exercise and review of medications. Next step, next click please. You undertake psychosexual counseling when there is psychogenic erectile dysfunction, mostly with performance anxiety, relationship dysfunction, some amount of depression, premature ejaculation or loss of libido. Then you go next click please. And when you expect the patient is a diabetic and 40 plus individual, you may suspect androgen replacement therapy. Androgens are available in the oral capsules or pellets. Oral capsules are plenty available in Indian market. German gel again is available in Indian market. Patches are not available in India. Short or long-acting intramuscular injection of testosterone undecanoate depot injections, which once in 3 weeks and 3 months you can go for that, or subcutaneous implants, which are not very effective in India, and mostly it requires a minor surgery. Next click, please. And in the first line, when after the androgen replacement therapy has been instituted, or even without that, when there is no deficiency, you resort to oral therapy, like I mentioned to you earlier, the phosphodiesterase type 5 inhibitors. Next click, please. When that is not very effective, either along with oral therapy or without oral therapy, use vacuum enhancement device, in which condition the patient fails oral therapy or along with oral therapy. The patient is on nitrate where you cannot use phosphodiesterase type 5, and then you have patient which prefers vacuum suction rather than intracavernosal injections. Next click, please. Now, second line of therapy, intracavernosal injection, intraurethral suppositories. Intraurethral suppositories are used with not available in India, but that is much safer provided you can access it because it contains prostaglandin even, alprostadil. But only thing, patient has to insert into pineal urethra with an applicator and inject it. And patient may find it cumbersome because it is semi-invasive. Now, intracameral injections are good to induce confidence in clients, but it's got a risk of priapism, and the doctors must learn the technique of giving intracameral injection without damaging the urethra. Next slide, please. Now, when the second line does not work out, finally you go for pineal prosthetic surgery, which only a specialized, all urologists cannot do that. Urologists specially trained in prosthetic surgery, they only can undertake that. Then you finally undertake this for the patient. But as I told earlier in the first slide, please always include some amount of counseling along with whatever medication advice you are giving, because the patient is always beset with doubt. The three main enemies of sexual satisfaction are fear, guilt, and anxiety. All that stem from ignorance. That is why we keep on telling our medical fraternity and other people, healthcare professionals, sex education is a must in whatever branch of medicine you are when your client comes to you. And sex counseling is important. And even if you're giving them drug therapy or giving intracameral injection or go for a pineal prosthetic surgery, you must give them some amount of counseling. Only then you're doing a good job. Thank you very much.
Thank you, sir. Thank you, sir, for the wonderful presentation. We obstetrician, we are not much knowledgeable about all these things. I think we have read only in books. You had given a good explanation with visuals, good visual impact. And when the patient comes to us, only we will manage them with the stress management. Stress management, as you said, the third partner, the relationship, building up of relationship between the couple. That all we'll advise usually. What about the pelvic floor exercise? Whether it will helpful for the male erectile disorders?
In erectile dysfunction, I don't think it is going to work out.
Okay.
But probably in premature ejaculation, it may help out.
Stress management, how far it will be helpful? Because even a 10-year-old kid now talking about stress and sedentary life, it plays a major role in erectile
madam.
dysfunction.
Stress management is important, but one thing, we are overusing the word stress.
Okay.
Right from Tiwala to the Prime Minister, everybody has got stress.
Yeah.
So when you ask people, everybody is saying, doctor, I am stressed out, doctor, I am stressed out. It is not that he is stressed out. He is unable to manage the stress. So we require to help him to learn to cope up with the stress. Use stress is impossible. It is important for us. Without stress, we cannot live. Stress is a non-specific reaction to any stressor. And without that, our human life becomes miserable.
Yeah.
It has to be used stress. Otherwise, you cannot be having distressed. So it's very important. I agree with you. Stress management goes a long way in the management of sexual problems.
Can I add one more
Yes,
suggestion?
please.
It is always a must that when a man comes with an erectile dysfunction, you have to examine the partner, female partner. That's very important. We will be very happy because if she has a vaginismus, he would have gone in for an erectile dysfunction. Without knowing the knowledge of the vaginismus, he may land with an erectile dysfunction, telling that he cannot perform sex without knowing the vaginismus. So it is always ideal that as a gynecologist, we should examine the female partner when a man comes with the erectile dysfunction. That I want your words and ideas about it, sir.
You are 100% correct, Dr. Jayarani. See, history gives us the clue. If the husband used to get erection initially, later on uses the erectile ability, always think about vaginismus. And number two, when you take a history of the patient, when you are trying to enter her, does she clench her thigh muscles or does she push you away? That will give a clue to you. So it is ideal for every single sexual problem, we examine both the partners. What I do is, I stopped examining the female clients since past 2 years because of many malpractices cases being foisted on doctors unnecessarily and consumer protection costs. I refer them to my gynecologist friend who will examine them give me a report. But we should not omit or we should not forget that vaginismus is also great part in lack of penetration.
Yes, sir. Thank you. Any more questions from Madam? Thank you, sir. Thank you so much for the elaborative thing and in a very
Also, it's very crisp and
understandable way.
points. Yes. The first line, second line, third line, so it's very easy to follow the case. It is very easy.
Thank you, ma'am.
Thank you, sir. Thank you.
Thank you.
Thank you, madam, for giving me the opportunity. Jairani, madam, thank you so much.
Thank you, chairpersons. Thank you, coordinator, for nicely coordinating the session too. We are very late in the sessions going on. So we are coming to the final session, and I'm very happy to introduce the coordinator of this session, Dr. Selva and Dr. Kavita.
Yes, thank you, Dr. Jairani ma'am, for inviting me for this webinar, and I thank Dr. Neeraj as well. I appreciate the Foxy Sexual Committee team for a wonderful activity. The entire 2020 has been a constant activity in spite of the COVID. I would now invite Dr. Jairani ma'am. Yes. Dr. K.S. Jairani Kamaraj, Director of Akash Fertility Center and Hospital, Vadapalni. She's also a member of VAS, Advisory Committee member, Managing Committee member of OXY, Joint Organizing Secretary of ISAR 2015, member of Board of Studies, Dr. MGR Medical University, lifetime member of FOXY, Society of Reproductive Medicine, and member of ISAR, and member of European Society of Reproduction. And she's received a lot of medals and awards. I would invite Dr. Jairani ma'am to moderate this very important topic, demystifying the female sexual dysfunction, which is very rarely spoken about and which has got a taboo to even speak about. So I really appreciate to bring out this topic for an open discussion. We move on to Dr. Jairani.
So Kavita, can you introduce the panelists too? I'll be happy that if they are
okay. Okay, ma'am.
So can I have the next CVs of the panelists, Sashi?
Yes, I introduce Dr. Krishna Surendran, my friend from Kanyakumari district. She is the director of Adarsh Vidya Kendra Trustee and joint secretary of IMA Nagarkoil branch. And she's won prize paper on West Zone Yuva Foxy 2009 and a Mox Quiz third prize winner in Pune 2008. And she's presented a lot of papers and posters in many conferences. And I invite Dr. Priya, gold medalist from Madurai Medical College, awarded as Tamil Nadu's Best Doctor Award in 2017, working as a senior consultant in ESI Hospital Madurai, consultant in Ishwara Hospital Madurai. I also invite Dr. Raja Ilavarasi, consultant from MS Hospital Trichy. Her educational qualification is MBBS MS Obstetrics and Gynecology, Fellowship in Reproductive Medicine from Ahmedabad, India. She's done publications on study of efficacy of pipil biopsy technique in diagnosis of endometrial diseases in abnormal uterine bleeding, and also on abnormal arrangement of arteries in upper extremity case report in the Journal of Anatomical Society of India. And I invite Dr. Rajapriya Ayyappan, one of a very interesting speaker, and the EC committee member of ATN RCOG, FPSI, OXY, and FOXY endometriosis committee member, secretary PIMA Women's Wing, secretary Indian Fertility Society TN chapter, best doctor award from IMA 2018, Inspiring Gynecologist Award, AL Mudaliar Fellowship Award, and many other awards goes to her credit.
Yes.
Dr. Vijayalakshmi Gnanasekaran.
Kavita, yeah, the panel is over.
Yes.
Thank you. Thank you, Kavita, for introducing the panelists.
Yes. Okay.
So, we are now... Vijay?
Jairani, madam.
Yeah,
I
Vijay.
think whether nature just took it up on its own to put in my slide because...
Please join. It will be very happy to have you, Vijay, with your dynamicity on this webinar also.
Okay.
Right.
Ma'am, what shall I do? I need to log in there because I have a talk.
Yeah, we'll finish up in 45 minutes. That time you can log in. If you are very busy, you send a message. I'll come. That's it.
You pinch me, madam, because I'll be there on the.
I'll do it.
Okay,
I'll do it.
Okay, right. Thank you so much.
Thank you, Vijay. So far, thank you, Kavita, for the nice introduction, and thank you, Vijay, for joining us. And we are now coming to the important session. So far, we are hearing more positive and demanding sex in the form of rejuvenating sex life at 40 and pregnancy and sexuality, all demanding sex. But now we are coming to a point where the sexuality is really questioned in a woman. That is a sexual dysfunction. Can I... I'll share my screen. Can everyone see my screen?
Yes, Dr.
Right. So here we are, an important topic on decoding the female sexual dysfunction. As we all know, so far we were talking about the sexual function, which is a very complex biological, psychosocial process, which is mainly coordinated by the neurological, vascular, and endocrine process. And human sexual function, which is a very important component of life, both for species propagation as well as the quality of life. And we heard about the male sexual dysfunction, which has been in practice over the past 50, 60 years. And from 60s after the Viagra, there has been an exponential research in the male sexual dysfunction and many researches, many advancement and many treatment for the male sexual dysfunction. But when you look into the female, who is always considered as in the gender also in the second way, though they have more prevalence of sexual dysfunction, their complication or their problem is less understood in comparison with the male sexual dysfunction. And this not only lead them to a difficulty, but there is also a lot of problem in their quality of life, causing a lot of negative effects on their mental health, their vitality, and also the women who are affected by the FSD are depressed, dissatisfied with their home life, and dissatisfied with the emotional and the physical relationship with their sexual partner. Everything comes into a problem, and definitely the psychological impact it causes to a woman has to be addressed in a proper way. And to address this and treat these women in the best way, how we are going to evaluate these women who have a problem of a sexual dysfunction, how we are going to diagnose her, how we are going to treat her. We have a great gynecologist here who are going to teach all the audience here that how they are going to treat the FSD patients by evaluating them, by diagnosing, by treating them. And we have with us Dr. Bhanumati, Dr. Krishna Surendran, Dr. Priya, Dr. Raja Ilavarasi, and Rajapriya Ayyappan, who will all be enlightening all the delegates, including me, with their answers, with their talk about all about the FSD. So before we go into any discussion, we'll just brush up the basics. The female sexual dysfunction, as told by, that is designated by WHO, the various way in which a woman is unable to participate in sexual relationship as she wishes. That's very important. A woman cannot perform sex what she wants to. So that gives her the greatest problem, what they call as sexual dysfunction. So when you look into the sexual function in a woman, it is like any other coordinated response where the multiple systems are involved. So the sexual function results from the neurovascular processes, and it is triggered by the psychological and the hormonal inputs. So for a satisfying sexual experience, the very important structures, the vagina and the clitoria, should get a proper blood supply. So here we have to clearly note that these two organs, that is the vagina and the clitoris, has to have a proper blood flow, proper nerve supply, and that has to be triggered by the hormone and the psychological ways to get a proper sexual function to happen. So this has been proved without doubt that any vascular problem affecting the internal pudendal artery, which supplies to the vagina and the clitoris, when they are having a disease like atherosclerosis or being traumatized in a trauma or affected by radiation or with pelvic fractures, they can cause a lowered blood flow, and thereby this type of women will definitely end in a sexual dysfunction. Impact on the sexual functions of the women. So for a proper sexual functioning, we need a proper neurovascular, hormonal, as well as the women's psychological aspects, which are very important for a proper sexual happening. A word about estrogen and testosterone. I know everybody knows about it. You're all gynecologists know the estrogen play a very important role in the vaginal epithelial maintenance, its proliferation, the stromal cells proliferation, the vaginal soft, smooth muscles elasticity, and the structure coherence. Everything is maintained by estrogen. And testosterone, it acts mostly on the sexual desire, arousal, and the libido. So all these things put together make a woman have a proper sexual function. So if something goes wrong, then they end up in a dysfunction. And that's a simple expression of the sex as a natural biological phenomena, which starts as a sensory stimulation, which could be either a visual or an auditory or a tactile or an emotional. All these sensory stimulation leads to an increased peripheral blood flow and increase of vasocongestion in the genital organs. With continuing stimulation, there is an increased pelvic muscle tension, and the vasocongestion increases and they reaches a plateau, and ultimately they end in an orgasm where the brain discharges certain discharge which gives a genitopelvic muscular contraction, which the women feels as an orgasm, which is felt as a lower 1/3 of the vagina gets repeated contractions, which she feels as a orgasm. So after the orgasm, there is a resolution phase where she ends up in a non-stimulated state. So the essential component of the sexual response depends on adequate functioning and interplay of the hormones, nerves, veins, arteries, genitopelvic muscles, and the women's psychological state of strong mind. So these are all the very important steps. With this basis only, Master and Johnson and modified by Kaplan, they have designated the sexual response cycle. That's the Master and Johnson cycle, where the sexual response cycle starts with an excitement and reaches a plateau, and then orgasm and resolution. And in Kaplan's model, he said that a desire is very important to start the excitement. That is very important. Once the desire comes, then only the arousal and the excitement happens. So these are the various response cycles as designated in a women sexual functions. So the sexual dysfunction is classified as two important things, that is mainly including the mental and the psychological, which ultimately ends in a lack of sexual desire, arousal, orgasm, and pain disorders. And a very important, all these dysfunction should cause a distress. Then only we call them as a sexual dysfunction. Because these sexual problems, if they are alone or present, we call them that the women has a sexual problem. But when it is going up to a level of causing a personal distress, then we call that this woman has a sexual dysfunction. So the types of sexual dysfunction, there is a loss of sexual desire, impaired arousal, inability to achieve orgasm, and pain during sex. So now let me ask my panelists, Dr. Banamati, you're here?
Yeah, I'm here. Yes.
Yeah, the classification actually, it is the Diagnostic and Statistical Manual of Mental Disorders 5, recently modified from the 4th one. And there we have one desire and arousal into one category, and the aversion is been taken out. And the second one is the female orgasm disorder. And the third one is the genitopelvic pain or the penetration disorder. And it has got the dyspareunia and the vaginismus is included in it. So it recently this has been our classification. Earlier it was the arousal disorder and the aversion disorder was there. Aversion was taken out.
So as she rightly said, the classification of FST, the DSM-5 categorized as a FSIAD, that is female sexual interest arousal disorder, as one category where the arousal, excitement, everything comes into role. And second is the orgasmic disorder where the women doesn't have an orgasm, and the pain disorder where it could be a genitopelvic pain or a penetration pain. And the last one is the substance mediated sexual dysfunction. So next, coming to the FSIAD, can you define that? Because it's very important that we should know the definition. Then only you can classify the women having this problem with this criteria. So Dr. Krishna, can you enlighten us about the FSIAD?
They're basically 3 out of about 6 or 7 criteria. They should, and each of it, and it should be at least a duration of 6 months. So either your interest in the sexual activity, they shouldn't be having any sexual thoughts or fantasies. And even if the partner initiates sex, they shouldn't be responding to the sexual activity. This, when you say sexual cues, it could be a visual, even written. It could be a genital or a non-genital. It need not necessarily be a coital. It's not only during the sex per se that she should not have any fantasies or thoughts. And they should be at least for a minimum of 6 months, which is quite a long time. Only then can you categorize them into a arousal disorder as such. They are not moved by any of these criteria at all.
So it is totally a lack of sexual interest. So that is a very important one. Coming to the next, the female orgasmic disorder. How you define this and what are the criteria to say about the female orgasmic disorder?
Madam, the female orgasmic disorder is a marked delay in or marked infrequency of, or either there is an absence of orgasmic, markedly reduced intensity of orgasmic sensation in almost all or all occasions of sexual activity. And this disorder should be also present for a duration of 6 months, and it produces significant distress in the couple. Yes. Then we classify it as female orgasmic disorder, madam.
Yeah, it's correct. There could be a total anorgasmia. Sometimes they say in a study, 40% of the women have total anorgasmia all through their life. They never experience an orgasm, and nearly around 12 to 25% of the women, they go through a secondary orgasm. Initially, they must have had an orgasm, but some situations prevent them to get an orgasm. So when a woman comes with an orgasmic problem, we should ask them how long they have. Do they experience anything earlier, or do they experience only with some situation or some partner? That's very important, because sometimes they get orgasm with a good surrounding ambience, but sometimes they won't be getting. So very important, when you come across or when you diagnose an orgasmic disorder, you have to ask the detailed history and classify accordingly whether it is an anorgasmia or a situational or with some certain partners. So next, coming to a very important problem, that is the genitopelvic pain penetration disorder, which is a very important disorder from the gynecologist point of view, because the patients mostly come to us. Yeah. So can anyone tell me how you designate that and what is the criteria?
Disorder is defined as the persistent or recurrent presence of one of the following. As such, they might have a difficulty in intercourse, or they can have a fear or anxiety about that intercourse or any form of vaginal penetration, or they can have a vulvovaginal pain or pelvic pain associated with that vaginal penetration, which in turn leads to tightening of the pelvic floor muscles. So all these which have been present for a minimum period of 6 months and causing significant distress to the patient, only then you tell it as a genitopelvic or penetration disorder. Earlier, dyspareunia and your vaginismus, which were separate entities, have been included under the penetration disorders now.
That's right, Ilavarasi. You have been elaborating it very nicely about the sexual pain disorders. How to differentiate between the dyspareunia and the vaginismus is very important, because vaginismus is a psychological problem where the woman doesn't have any problem in her genitals. It is her mind or it is her psychological problem that makes her go for a involuntary spasm of the lower vagina, which doesn't allow the partner or anything to penetrate. Whereas dyspareunia is because of some organic problem she had. She keeps, there is a pain on touching or with a sexual intercourse. So that's very important. Next, very important content of this dysfunction, the substance or the medication induced sexual dysfunction. Can I have Rajapriya to answer this?
We always, whenever we discuss with the patient with respect to any sexual problems they're encountering, it is important for us to understand whether they always had that problem or after a particular onset. So it's like that onset when we discover that there was a particular medication she was on and subsequently her sexual behavior to her partner has changed, then it is knowledge for us. So the treatment history of what drugs they are on will help us. So supposing she's on any psychological drugs like benzodiazepines or antipsychotics, subsequently the prolactin levels can get affected and she can have problems with the lack of interest in sex. Or any drugs wherein the estrogen balance is lost, she can feel some lubrication problems. Or she's on tricyclic antidepressants, particularly if they are on cardiovascular drugs like antihypertensives or any anti-angina related treatment, you will find that the person was having a quality sex, but after using a medication, the quality of sex has deteriorated. So it is important that way for us to understand that iatrogenic kind of situation happens.
You're right, Priya. So that is a crispy way of describing the definitions of the FSD, the hypoactive sexual disorder. There's a chronic lack of interest in sexual activity, and the aversion disorder, arousal disorder, orgasmic disorder, and dyspareunia, vaginismus, and the non-coital sexual pain, and the drugs which induce it. So as rightly told, discussed by my panelist, these are all the various sexual dysfunctions and the definitions which you have to look upon when a woman comes with some problem. So initially, when you are evaluating a woman or when she comes with a complaint, these are all the things that should come into your mind. She belongs to which category and how you are going to treat her. What is the cause for this? What is the basis of her problem? That this definition, if you are all well aware, then you can criterize the patient to which criteria she belongs, and so that you can focus the treatment pertaining to the problem. And very important is the medications, because we all know that all the medications have a problem oriented towards the hormones, as rightly told by Priya, that estrogen, when anything you are taking as an anti-estrogens, will have an impact, because many a times the hormones are the one which gets affected by the drugs, which can cause a problem in the lubrication or in the pain, which may cause because of the dryness, and they may go or land up in a problem with a sexual dysfunction. So very important, you have to completely evaluate her with all these things in mind. So I would like to ask all my panelists, at least two of you. Priya, you can answer this question. How many percentage of patients you see in your practice affected with female sexual dysfunction?
Like as today's discussion went on, I think a huge chunk are actually having this problem. Sometimes it's over 20 to 25% of our female clients. It's only whether they voluntarily come out with this particular complaint or whether we as clinicians are able to tap out the information that this is what is happening in their bedroom. So usually they never volunteer the information, but I guess there is lots to be. This particular program itself is trying to bring out that each gynecologist shouldn't shy off from the question of just not routinely asking how often do you have sex in a fertility clinic, but really what is happening, like probably 20 to 30%.
Yeah. Krishna, can you tell me how many percentage of patients you see in your clinical practice affected with FSD?
I beg to differ, because I think this problem is a lot more than 30%. I would even go up to a 50% at some point in their lives, not necessarily in an infertility clinic. It'll definitely be more than 50%, because I think, I'm sure if you ask, or 60 வயசு அதெல்லாம் பை முடிஞ்சு எவ்வளவு வருஷம் ஆச்சு, that is a normal this thing you hear. So, I mean, it's really impossible to say. It's only a select set of population that you would see and ask them for this kind of this thing. If it goes on to a little older population, and I'm talking about, because mine is a very small, it's not a metro city. So, people are still very hesitant to talk about sex. So it's, I would even go up to more than 50%.
So
I guess I should agree with you, Krishna, when you talk about the entire age group.
Yeah. So it's at some point in their lives, it's definitely more than 50%.
So I agree with all your panelists, but very interestingly, if you see the data, there is 71% of the women in their reproductive age group go through some problem of sexual dysfunction over the lifetime period. So it's all depends upon the various stages of their age group, but all women up to 70%, they go through some sort of a dysfunction throughout their reproductive age life. And the very interesting latest survey said that men, only 30% of the men report sexual problem, whereas 43% of the women suffer from this sexual dysfunction. So such a big population is having this FSD. And
this,
our clinical practice,
this statistics is 43 statistics, I think it's from France, ma'am. I happen to read it.
So yes, that is
really not applicable.
Why the disparity so much is prevalent in the society, but only a few are coming to us. So what is lacking, and what way our gynecologists or the lady doctors has to do, why it is happening? If you look into the data and the research, it is mainly the women are unlikely to discuss it, as rightly told by you as well as by Rajapriya, that the women they are not likely to come out to discuss with their healthcare providers unless they are asked. That is a very important one. So if you ask a woman, do you have any sexual problem? She will immediately say, no, madam, we are happy about it. But if you call her and ask her in privacy, you have a concern, anything that affects you, either you feel psychologically that you are not satisfied, whether you have anything, a problem with your husband, if you ask her in privacy, definitely she will open out with so many issues. But when you ask her very plainly, that is what the guidelines says, what you should ask. If they say no also, you should ask them, because there are a lot of barriers to the treatment, because even the doctors and the gynaes, we don't have time to sit and talk, because it is going to be a great counseling, and definitely we don't have much of a treatment available what we have to do for the patients, because we are not aware. That is also very important. We don't have a proper training, we don't have a proper drugs awareness. That is why we have this CME right now. And also the patient feels very uncomfortable to talk with them, and also there is a confidence issue also comes to the patient, whether to disclose it. Will I disclose myself, my her esteem, all these things comes into her role. So that is a very important one. And very interestingly, if you look into the male this dysfunction, it is almost 60 years down the lane. But if you look into the women, it is only from 2000 or 1990s, there has been a lot of researches which are coming out on FSD. Earlier, they used to think it is only a psychological problem or it is a man-oriented problem. But now they are coming out with a lot of research to say why it is caused, what are the reasons, how we go about it, and a lot of other things are coming into the clinical scenario. So when a woman comes and asks you what you should do, that's what the guidelines says. The guidelines says that you have to ask them a proper history. Are you satisfied? You should not ask you have a problem. You should ask her whether you are satisfied. That's the first question you should ask your patient. If they say yes, then you feel that they're okay. But if they say no, then you have to continue the discussion You have to ask them how much they are dissatisfied with their sexual dysfunction. You can even give them a questionnaire. You can give them a FSFI questionnaire or a sexuality questionnaire to ask them how their interest, how their genital sensation, how they feel about the genital sensation. Do they feel well lubricated, or is there anything, a dryness? Whether they have any issues in orgasm. All these questions are the standard questions you have to ask as a gynecologist, as a primary care physician to your patient if they have any issues with the sexual satisfaction. So that's very important. So we obstetrician and gynecologists should initiate a clinical discussion of sexual function during our routine care visits. Always spend time to ask these issues to your patient, which will improve your confidentiality with the patient, also will improve your rapport with the patient, and also she will feel that she's discussing something very personal that will give her a confidence in you, and give her a small checklist or some feedback pamphlet which she can fill it up, which will validate your doubts what you should ask. So very important, there is an FSFI index that is a very difficult one, but you can prepare a proper format of questions for your patient's knowledge. If they're educated, you can give them a FSFI index chart. But if they are not educated, you can give them a proper questionnaire, which will give them a proper opening up whether what the problem they have, how they have to discuss with this. All these things are very important in your clinical practice. So up to this, we have known about how we are going to start the discussion. And coming to very important part, what are all the causes or the etiological causes which can cause FST? Because we have to identify who are the women who is going to get affected by this. Some patients who are taking some drugs, definitely they may have a problem. Some patients having some disease may have a problem. I would like my panelists to highlight a few words about the etiologies one by one, because if you look into this list, a big list, it starts from A to Z. Almost you can say from A to Z, there are so many etiologies and risk factors for the FST. So much is there. So just a few words from each one of you in a minute.
If you're roughly able to put it as whether it's a psychosocial problem they're going through, or a partner related concerns they're going to go through, or if it is anything organically going as a problem, or a new medical or a surgical factor, say a post-hysterectomy situation, if you're able to put it in some broad categories, you will probably decipher what is the cause of their FST.
You're right. So I have made a list. I have made a list as ABC. So
I think one of the biggest causes would be a sexual abuse. I think that is definitely, because when you come to that, you see more and more, because the census right now is 1 in 3 girls and 1 in 7 boys as a child abuse. So it's the consensus are large. So when you think about it, I think that is something we really miss, and which I think during this thing, the more I work in it, I think that should come right at the top of the list more than anything else.
You're right. So
anything
and also
relationship problems also come into picture, especially in the puerperium or post surgery, or any long-term illness, something like that, or the lady is away from the partner, both of them are away. All those things, relationship problems really end up in such things, and difficult to solve it if untreated earlier.
Even endocrine disorders like hypo and hyperthyroidism, hypercortisolism, hypoestrogenism, hyperandrogenism, all of it can lead to diabetes mainly. All of it can lead to sexual dysfunction.
And history of long-term psychiatric illness, history of taking long-term psychiatric drugs like SSRIs, histamine blockers, hypertensive medications, proper detailed history taking, madam, past history and the present history, any history of recent illness with medications, how long she's taking and whether it has any impact.
I think pregnancy also, ma'am. Pregnancy, I think, is one of the biggest causes for sexual.
So
even premature ovarian failure.
Right.
Yes.
Hormone.
And low self-esteem, body
image, obesity.
All those things also really put her into trouble.
And also lack of time, madam, working, managing 2 situations, home and work. also causes a lot of female sexual dysfunction, madam. And it is very common among IT professionals, madam, who do a lot of night works, night duty, night job, meeting the partner in the morning, the partner is going for work in the morning. And when she comes back, the partner goes out. This history I often see among so many couples, madam. Both are not meeting.
Yeah, that is what we call as DINS. That is double income, no sex.
Yes.
That is what double income, no sex. That is a very common one. She goes for one shift and she goes and they never meet at all. That is a double income, no sex. That's very interesting. As rightly elaborated by my panelist, there are very number of causes, very numerological causes, but very important causes you should know, as rightly insisted by my panelist. The first thing is the psychological causes, which is a very important cause for a female sexual dysfunction. Can anyone highlight about this psychological causes which can cause an FSD?
It can be, she can be a child of a childhood abuse. So, or she can be from a broken wedlock, or she can be a child who has grown up with parental disputes, which has led to a lot of psychological trauma. Or she can be a person who has had a chronic psychiatric illness, chronic depressive illness, or she could have a family history of manic depressive psychosis, which in turn is precipitating an FSD in her. So many psychological causes can be there. She can have a fear about sex, phobia, sexual phobia, you call it as. So all these can lead to psychological disturbances.
What about the relationship? Can anyone highlight about the relationship?
I think actually really important, ma'am. Sometimes the first marriage doesn't work, the second marriage works. So that's something like we say situational. So I think communication is key for any relationship to work. And in any marriage, I think till the very edge, both of them have to live up to each other's expectations. Just because they are married, they cannot take each other's feelings for granted. And that's something we have to constantly keep both the members of the couple educated, that they have to have an open communication and tell them, even if they are not in a mood, they are not in a mood. So you have sex if you have the
respecting
mood,
each other's,
you have energy. Absolutely.
respecting each other's
feelings.
So very important is when a sex has to be, it is not made in a bed. It is made in between your head. That is a brain. That's a psychological thing. It's very important to initiate the sex. That's what the Kaplan said, that the desire, more than the it's the desire. That desire comes with proper communication, proper intimacy. It is not the sexual act that gives an orgasm to a woman. It is the intimacy, as rightly told about that communication, the expression yourself, the self-esteem, the feel that you feel about your body image. All these things form a very important factor for a proper sexual dysfunction. When they are jeopardized, these women definitely end in a female sexual dysfunction. So all these things, why we are discussing so elaborately is, so in your busy practice, if you come across such vulnerable women who have a problem of some medications or a psychological abuse, or who have a past history of a sexual abuse, or coming from a relationship problem, so you can concentrate on this group of women so that you can correctly treat them and you don't leave them to go into a problem. So these are all the population of the women that you have to concentrate. Mostly they are the abused, the perimenopausal women where they have a lack of estrogen, and the pregnancy, and also the gynecological cancer and the treatment related to it. They are all the high susceptible group people who can face with the female sexual dysfunction. So we have to concentrate on these patients mainly without losing them, so that you can give them a good sexual life. That's very important. That's why we highlight on the etiologies, common causes, everything which comes into a problem. So now we have diagnosed, we have sort out the etiological factors, how we are going to manage them. Because we all know there is a limited, only few drugs are available for managing an FSD. So can anyone tell me what are all the approved drugs for the management of FSD?
I think we should start with estrogen, being the premenopausal group. I think that would be the most logical thing, because that is, I think that is where we see a lot, because there are more and more menopausal clinics these days. I think that is where we see the most number of people needing hormone replacement therapy. So estrogen does play an important role, especially topical, even topical this thing. Osfeme.
Yeah,
Osfeme, yeah. Yeah. And I was looking up for
flubanserin,
fibanserin and bremelanotide.
Agonist and
bremelanotide.
Yeah, and bremelanotide, which is a melanocortin receptor agonist. Both this bremelanotide has been approved only in June 2019, which is a subcutaneous injection. It is FDA approved and it's taken just 45 minutes before sex. So, and flubanserin requires daily dosing, but the only problem is that the side effects are like hypotension, dizziness, and it should not be taken with people who are used to taking alcohol. So,
you're right. You have given an interview about ADI, which is the flubanserin, which is available in the international market, not it's in India. So it is not approved here. So we have very less number of drugs. But before we go to the treatment, we have to have a proper protocol of how you're going to completely evaluate. What are the investigations that you have to take for a patient when they come with a sexual dysfunction? We have to have a protocol. Can anyone highlight in all these things? How we are doing the history, physical examination, everything? That is very important.
In any case, history taking is very important, madam. A detailed history taking, whether there is a frequency, how many times a week or month, whether they are satisfied with the sex. Even there are cases with the non-consummation of marriage that also we have to properly illustrate whether there is any history of hormone intake, any medication intake, personal history, psychological history, everything should be taken into account. And then we have to do a proper physical examination, whether the appearance of the patient, any abdominal examination, proper abdominal examination, and gynecological examination should be performed. We have to do a proper gynec examination to rule out vaginismus, or then simple tests like Q-tip testing for vulvodynia, vaginal pH has to be examined, and some basic hormonal investigations like doing a basic hormonal profile consisting of a serum TSH, prolactin, estradiol, testosterone, and sex hormone binding globulin can be done, madam. And
so very important that when a patient comes, we have to ask important about the questions, and then we have to take an important history and the importance in the clinical assessment, and do a proper pervaginal examination, and then advise them depending on the problem, the hormonal profile and the other testing. So these are all the very important.
Add a point.
Yeah.
If you have especially a visiting husband, like he comes from abroad, just stays for a couple of months and gets back, recurrent UTI and recurrent candidiasis, that can turn the woman so paranoid. So even before he comes, she'll be so worried which she's going to land up in. So I think looking out for that coitus happening just once or twice the entire year, and also checking out for diabetes.
You're right. So we have to do all these basic investigations to rule out diabetes, thyroid dysfunction, and the hypoestrogenic conditions, and also prolactin, which is very important because hyperprolactinemia definitely can cause a hyposexual desire disorder. All these things has to be evaluated in women, and this is a big flow chart, and I will just put it in the website, or I will circulate it so that you can all go through it. This will give you a proper idea of how you have to establish the diagnosis of a female sexual dysfunction when a woman comes with a problem. What are the questions you should ask and how you have to proceed, which is a very important step in establishing the diagnosis of the FST. So when you're establishing the diagnosis, you have to see the domain, the duration, and the context. That's very important. Whether it is a generalized or it is a situational, as rightly Priya has mentioned about situational only. When the husband comes, she has a problem of pain there, dysuria there, burning sensation there, and that she never has earlier. So all these things could be an added factors when you are looking at women with a FST. So about the treatment, can anyone tell me about the off-label medications? We talked about the approved medications. There are only 3 medications which is approved by FDA. One is a topical estrogen, and second is the osfabinine, and third is the flibanserin. Flibanserin we don't have, but we have topical estrogen and ospina. And what are the off-label medicines we use in our clinical practice, or which is used but not properly proved their efficacy or approved by the FDA?
Sildenafil citrate.
Yes.
Testosterone.
Sildenafil.
Sildenafil.
Yes.
Sildenafil.
Yes. So
Lodosildenafil. We do
yeah,
use that.
the off-label medicine are very important are 4 medicine, which is the androgen testosterone. That is a very important one. And you can use, I think Madam has talked about that. So you can have testosterone, which can be used as a patches, or it can be taken as a vaginal tablet. And there is a DHA vaginal tablet, which also can be used for the FSD. They are all approved or they are used by clinicians, but they are not approved. But you can use it, give a trial for your FSD patients. So yeah, we'll talk in detail about all those things little later. Can anyone elaborate about the psychological interventions, what you make for a woman when she comes with an FSD?
I think in recent years, mindness-based MBCT has been gaining quite a lot of this thing. I think psychological, when it comes to vaginismus, you have to treat her, find out what the cause is, talk to her, take proper, especially when it comes to abuse. Those things have to be psychiatric treatments needs to be taken. And then
you can even give them sex therapies when they have aversion disorders or when they have arousal disorders. You can give them sex therapy, which requires repeated sessions. And then once the clinician gains the confidence of the patient, and then with repeated counselings, those disorders can be corrected.
You're right. That's a treatment for the psychological aspects. Very important is mindfulness-based therapy. When the woman is having multitasking women, she will have everything in her mind when she comes to the bed. So very important that we have to attend to her mindfulness therapy, as rightly talked by Dr. Neeraj in his presentation, that she has to keep all her checklist outside the bedroom. That will give her much more concentration or much more improvement in her sexual performance. That is a very important cause for FSD, and which can be treated well with mindfulness-based therapy and cognitive therapy, and also sexual therapy. And a lot of psychotherapists and sex therapists are doing a lot of therapies, which will definitely help them to tide over this problem. So our drug, which we can use, is the estrogen. Can then someone tell about a detail about the estrogen therapy, how we use it? What are the indications for that?
Premenopausal.
Estrogen?
Estrogen, it can be given as vaginal application, as mainly for people having penetrative disorder or postmenopausal women complaining of vaginal dryness. They can be given a topical estrogen cream. When it is associated with vasomotor symptoms, you can give it as a combination of estrogen progesterone pills, so that the vasomotor symptoms are also getting addressed in these women.
So what about when she's contraindicated for estrogen? You have any other drugs for the treatment?
Ma'am, you have estrogen receptor modulators. You can give them tibolone. Tibolone is one good drug that can be used in place of wherever estrogen being contraindicated. It has least side effects, and it's a good, wonderful drug to be used for hormone replacement.
Yeah, we have other non-hormonal medications which can be used in women who are contraindicated for estrogen. As rightly talked, that we can use a tibolone, we can use flibanserin, and we can even use buprofen, which is a very important drug which will help for the improvement of the, this is a type of an SSRI which is very important in the centrally acting, which gives them a good sexual dysfunction correction. That is very important. So you can either use a sildenafil citrate, as rightly said, that we have to do. What about the testosterone therapy? Anyone can elaborate on that?
Have a testosterone in a form of patches can be given 300 it's enough, but before doing that we must do the testosterone levels, and we see whether after 3 or 4 months recheck her whether it is giving improvement. If it is giving improvement, you can continue for 6 months. Actually it is not well after beyond that. If it is not giving improvement, it can be discontinued.
Yeah, so next coming to the treatment for genitopelvic pain. So how we are going to manage a woman when she comes with a genitopelvic pain? This is a usual common patient that we see in our clinical practice. They come out with that. They have a complaint. So how you are going to address these patients and how you are going to treat her?
Either you might have the dyspareunia problems or it can be a fear-based vaginismus. So if it is dyspareunia, we try to identify if it is superficial, vaginal, or a deep related to endometriosis or PID. And as you rightly said, we cannot jump into a laser treatment if it is not going to be appropriate. Most often, it is a lot of talking because it's the mindset which is going to make her dry if it's a psychological component. After making sure that some amount of counseling is done, using lubricants and vaginal moisturizers help them in if vaginal dryness is the cause. Sometimes they are even advised using some vegetable oils, coconut oil. Most married couples are comfortable. In fact, they themselves would say, we used coconut oil as a lubricant. And then you telling them about some pelvic floor exercises so that the toning up of the muscles is also there, which will help them with the pelvic pain. Or in certain cases, we also tell them to take some anti-inflammatory drugs so that the pain can be alleviated during the sexual intercourse, or maybe a warm bath before sexual activity. So you have to decide depending upon what suits and satisfies the patient best. And you have to also remember that you're dealing with dyspareunia or vaginismus as a different situation.
So very important we have to educate them about the vulvovaginal anatomy. We have to educate them about the cause why they have the pain. It could be a vaginal douching, whether she's using some cosmetics, some deodorants, which might be causing this irritation or pain, or a pain in the vagina. That is very important. We have to ask a detailed history. And also we have to see about the undergarments, her pad, the sanitary hygiene is very important when you come across with the pain. So that is very important because vaginismus and all, it comes as a different entity. But in a gynec practice, they come with some pain, which is always a superficial pain, usually caused by this contact irritants. So we have to rule out this contact irritants, and some skin problems also can cause. So you always have to have an open mind when you see a patient with a genitopelvic pain, which is very important in our clinical practice. Kavita, do we have time for the cases, or I think what is the chairperson's idea? We have 2 cases to discuss. If time permits, we can go ahead.
Probably one more case, ma'am.
Yes. So I will go to the cases straight away. A very important one point I want to insist here, that when you come across a woman with FST, when you are treating her, you always have to keep an open mind that whenever it is, when you're going beyond the limit of not correcting her, give her the good suggestion of referring her to a sexologist or a sexual therapist, which will give them a good care for completely correcting the problem if you feel that it is not an organic problem. So if it is a psychological problem which cannot be corrected by a gynecologist counseling with your counselors, it is best that you refer them to a therapist, which will give them a proper solution to their FST, which is very important one, at which stage we have to go for this. So we come to the case number 1, which many of you are very interested, that this is a case, 27-year-old Mrs. K, married 10 months, not able to have sex. She's averse to sex. On suggestion of a gynec examination, she's very scared. She's unwilling, keeping her thighs abducted. You can't even make her lie down in the couch for examination. So can anyone tell me what is the diagnosis? It's very clear and obvious.
Vaginismus.
Okay, so that's the case of a vaginismus. So can anyone define what is a vaginismus?
Vaginismus is the involuntary spasm of the outer 1/3 of the vaginal muscles as a result of vaginal penetration, or even on the thought of sexual stimulation, she can have this vaginal spasm.
So it is the sexual stimulation alone or anything else?
Even the fear of
it is anything that penetrates the vagina. That is a very important one. She never allows even even touching the vagina. Touching the vagina. Even she can't insert, in Western countries, the tampon insertion itself is not possible. So that is the type of psychological problem they have with the penetration. It is not only the penis or the sexual act. It is anything that can penetrate. It's a phobia that she has of the vaginal penetration, which leads to the involuntary spasm of the lower 1/3 of the vagina. So that is the classification of the DSM-4 criteria, which says that the recurrent, persistent, involuntary spasm of the musculature of the outer third of the vagina that interferes with any penetration, which may be a finger, which may be an object, even if the patient or the woman, she wants to do it, even if she wants to have a desire to have a sex, but still she won't be allowing the touching of the genital organ. That is what we call as a vaginismus, which clearly differentiate this from any vulvodynia. That is a very entirely different entity. So we have to address this. Very important that she don't have any problem that's there. Everything is normal, but she has an impulsive psychological problem, which makes her go for this problem. So this is a very important cause for the unconsummation of the marriage. So they have a fear of penetration. Can anyone tell me how much is the incidence of this vaginismus cases in the practice?
Somewhere around 7 to 12%.
Yes.
10%.
So yeah, around 5 to 15%. And if you see in our, we have done a study in our practice where we see both fertility as well as sexual medicine. We come across 22 to 23% of the women have vaginismus. The men come for the erectile dysfunction. When we check the women, they may have a vaginismus also. So in that way, there is a 22 to 23% in prevalence in our patients.
Because
And
the referral, in a referral setting, it should be that high. Right? No?
yeah. So
No, it is high.
I think most of the infertility centers we see so much.
Yeah. So many a time that is the cause for the infertility. When you correct the problem, they will have pregnancy in the bed, not in the lab. That is very important. So what are the causes for the vaginismus, and what you should what is the important thing that you should do when a woman come with a vaginismus to you?
Previous abuse history is very important.
Yes. Sexual abuse. Yes.
The
History is very
childhood
important.
development, how she was-
Painful first attempt of coitus.
Yes.
Painful first attempt of coitus. No proper sexual relationship. Absence of foreplay. And unexpressed negative feelings towards her husband. And she strongly believes that her vagina is too small to accommodate the erect penis. Lack of intimacy. And there are certain people who believe that it is a sin to have sex. And they are brought up in a way from their family, two religious Orthodox families, and tension, pain cycle. She thinks pain is there and then have vaginismus.
So that is very important. Even this,
or somebody.
Yeah. Tell me, please, madam.
Some wrong inputs or some made her afraid of the act itself.
Yeah, you are very correct.
Told.
Yeah. So when we did a detailed history or an input from these women, of this 23% of the women, what we could find out is, as rightly told, that sexual abuse is the first one. Second is the orthodoxy. Third is the cultural concept that she has, the belief that she has it's a sin, or it is not, she don't like to have a sex with a partner. That is all the very important cause for this problem of vaginismus. So when you look into the very many studies, many things says that the strict religious upbringing is a very important cause. That is what they say. And the sexual molestation in a younger age, that is a very important cause, what they've noted for the vaginismus. Can you say anything an organic cause for the vaginismus?
Yes, when they have hymenal abnormalities like partial imperforate hymen, or if there are congenital anomalies of the genital tract, or in some women who have vaginal tumors, or if there's endometriosis leading to a vaginal a patch deep in the pouch, in the posterior vaginal pouch, or it can be because of pelvic organ prolapse. So in turn leading to vaginismus because of secondary vaginal dryness.
Yeah.
So there are so many other causes. Yeah.
So that's correct. So we have to rule out an organic cause even when a woman comes feeling that she has a psychological problem, but still it is our responsibility to examine her thoroughly. Even if she doesn't allow, we have to do an examination of anesthesia to rule out any other problem she has, which may lead to the vaginismus. That's very important. So how you grade this vaginismus? Because some women, they are very comfortable. They will come and lie down for examination. But when you put your one finger, which will not allow. For some women, they won't even come inside the room consultation. They will be sitting outside crying. Some women, they will be bold enough to say, no, doctor, I'm absolutely all right. That's what they said that. But when you try to put a speculum or when you try to put 2 fingers inside, they will keep it very tight, and you will really sometimes. I have seen
Hurt your finger.
where
Hurt your finger. It's very painful.
I could not even move my fingers for at least 1 week. So much of tightness they have. So how you grade this vaginismus?
Depending on how the movement goes, like supposing the first degree vaginismus, as you said, with a little bit of coaxing, if they come to the table and they lie down and then you're going to talk to them saying, I'm going to use some lubrication, I will not hurt you, at any point you can stop me, and you win their confidence, they will allow you to examine. In fact, sometimes we'll end up teasing, like, if you're allowing me to, why not your husband? So that group, usually your counseling will help over a period of time. You will, as you said, they will end up procreating in the bedroom. The second degree is a little bit of more coaxing, but you'll find the minute you try to put your finger in, they will start, they cannot relax. The third degree is consciously, you'll find that they are tightening their muscles and they would just elevate the buttocks. It's like, even if they want to allow you to examine, all this you will be detecting during the gynecological examination. But the fourth degree is when they will elevate the buttocks and classically adduct both their thighs. That is a time when you are prone for hand injury and finger fractures at times. And there is still worse when you are never seen the patient in the OPD, or you fail to examine the patient in the OPD. You post her for the follicle tract thinking like, oh, she's a very nice patient, and you'll find the vaginal probe you insert, the next patient will not come to the scan room because they'll find that a ruckus has happened in the scan room. So these happen especially when somebody refers a patient to you for a follicular study and you really don't know who that patient is. So sometimes you'll have even a vasovagal attack happening and you will feel so bad that you spoiled your day and her day if it is the first thing happening in the morning. So I think it is so important for us, just by the cues they are giving, what is going wrong in the degree of vaginismus they are going through.
Yeah. The very importance of this classification or grading this vaginismus is for the treatment purpose. So how we are going to see, there are 3 things that you can incur from the type of vaginismus. One is the abuse. If they have a sexual abuse, and the psychological one, they always have a higher degree of vaginismus. And the women who are orthodox and religiously more into it, they may have a simpler vaginismus. Once you try to correct them, educate them, they will be cooperating. So these degrees of vaginismus are very important for planning your management, how you're going to manage these women with a simple counseling or some therapy, or going to a serious counseling aspects, or making some other treatment modalities in the form of a psychological medications. All these things has to be kept in mind when you are classifying this women degrees of vaginismus. Very interestingly, there are some types also. They can have a primary, the secondary, or global, or situational. Primary, they're never able to have intercourse. Secondary, they must have had previously they would have been very comfortable, but secondary, they go for a vaginismus. It is usually associated with a normal delivery. When an episiotomy sutures have been tightly put and the introitus have been narrowed, they come for the secondary vaginismus, or some problem with an infection. Usually it is secondary to some infection. They go for dyspareunia or a marital conflicts, which are the main important cause for this secondary vaginismus. They would have had a proper sexual life. Either they could have been separated by some marital conflict or a relationship problem that must be inducing this type of a problem. And global, that is a very severe one, and situational only for certain things, like as you said, for the transvaginal examination or a pelvic intercourse, they may have the problem. So this is how it goes. It either goes for a relationship breakdown or it goes for an infertility. And sometimes when they don't do a proper correction, that may end up in a divorce also. So all these things you have to keep in mind, because the very important thing is it is a very correctable problem. If you correct them correctly, they can have a good sexual life, they can have a good fertility also. So the treatment part is very important. Can anyone tell me what is the step of treatment that you will take into this patient? Yes?
With vaginismus, first we rule out the primary cause of vaginismus. and treat accordingly. If it is mainly psychological, then give her psychotherapy, cognitive behavioral therapy. It is all the same. But when it comes to drugs, you don't have much drugs to do with it. But there are few trials done with botulinum toxin, which has been injected into the puborectalis muscle for muscular relaxation, and they have seen results with it. Or they have given nitroglycerin ointment to be applied to the vagina before intercourse, so that there's vasodilation and little relaxation. But there are not enough RCTs to prove it. But when this vaginismus is associated with the sexual phobia, you can try with tricyclic antidepressants like imipramine, which have been given in doses somewhere between 30 to 75 milligrams. Or you can, when it's associated with anxiety, you give them anxiolytics, benzodiazepines like diazepam, so that her anxiety is relieved, which in turn relieves her vaginismus.
So that's correct. But I want to add up one more thing for all of you. It is the dilatation that is very important. You have to tell about the dilators, which is very important. That is what we call as a guided tour. We have to explain this. That's very important.
Fingers, I think, and then the cones, and
Yes.
bigger and bigger cones.
Yeah,
Yes.
we have to educate them about the anatomy. We have to educate them about the psychological thing behind it. And we have to talk with them about why it has been caused. And then you have to plan the treatment of approaches, how you are going to do the approaches. That is what we call as a guided tour, which is very important. You have to educate the women about the gradual self-dilatation of the vagina, which is a very important one. And if you do that step by step, within 15 days, she'll be perfectly all right. But it is indicated only for the type 1, type 2, and to a little extent to the type 3. So all these 3 grades of this vaginismus can be corrected when they are given a proper guided therapy of vaginal dilatation. That is the dilators. There are very many dilators, which are manual dilators. The fingers, as she said, that the commercial dilators, which can be different type of tampons also you can use, which can be used for the dilators. And there are some special dilators which are available in different sizes. And you have to educate the women how to go about it. It should be a gradual one with the fingers first, and then go with the dilators step by step. And every time you have to ask for a review of her, how she feels about it, how she is practicing. It is something like you are stretching the vagina. If it is, you have to educate her, because this vagina is going to deliver a 3-kilo baby. So much stretchability it has. So only one thing is the fear, the pain. That has to be elevated with proper lubricants, and a gradual dilator will help her definitely. And as drugs, I think Ilavarasi has talked well about this. A dose of imipramine can help for severe phobias. Women who have a severe sexual phobia can be given a trial of imipramine, and that will give her a more of a mental compliance to face this pain of vaginismus. And benzodiazepines, relaxation, there are some studies, but nothing has been proved very effective like the dilators and the guided tours. Anyone in the panel, something you want to tell about a surgical? Is there any surgical remedy for vaginismus?
Anesthesia. No organic cause, it is not
Examination and anesthesia.
So, Rajapriya, you said that surgery will you do for a patient with vaginismus?
No.
No.
If I see an organic pathology, definite no. Because it will unnecessarily scar the place and it may make the problem worse.
Worsen the problem. Maybe
And they may think that this is going to make things better, and after that you will lose the patient for sure.
Yeah.
What about Ilavarasi? Will you advise?
No, definitely not. They have been doing vestibulectomy and all once upon a time, but now it is totally obsolete and it is contraindicated. Yeah.
What about any other panelists who want to defer this idea of surgery? Because the Fenton surgery, somebody said, do you advise Fenton surgery?
No, unless it has been proved otherwise. Some people do come to us asking that, it is thick. Especially the husbands do come. I think there were few very few cases. Like I said, I haven't done one in the past 10 years. So it's been a long time since I've done it.
So
my mother used to practice it. I don't.
So in the modern sexology, there is no role of Fenton surgery at all. But only one thing, if they have any organic pathology like a septum or a stricture or a thick muscular imperforate hymen, then only they need, even then, the thick imperforate hymen also, you can do a dilatation. If the women cooperates, that will definitely give her a much space for a proper sexual act. So that surgery is not there for the vaginismus. So to conclude, I think only one thing I want to differentiate here. Will you, any one of the panelists, can you differentiate between a vaginismus and a vulvodynia? Because many a times a woman comes with the pain, I can't do a sex. So immediately you come to a conclusion that she has a vaginismus, but she may be having a different problem. How you can differentiate the vaginismus and vulvodynia?
The swab test.
Yeah, got it.
I think the swab test is you have to touch it in various places and where the pain is more. So that is how you diagnose a vulvodynia. It will be an exaggerated pain when certain
point in the vulva has been touched. That is called provoked vestibulodynia.
Vestibulodynia.
They also come like a pain or discomfort, or they cannot consummate the marriage, but they will definitely have some points of vestibulodynia. That is a criteria, the Frederick's criteria. They have given these points. That is, it's a generalized one, or it is a vestibulitis syndrome which is provoked. So these are the important points that you should remember, that this women's vulvar pain is always a constant, occur only in one point. If you touch or press at that point, that she will have a pain. So this is usually very common in the perimenopausal and the postmenopausal women. And in the older women,
Jairani ma'am.
yes, we are finishing.
Yeah, madam, I have to log. I have already logged in the other program. My session is going to start. So just give me a few minutes because I'm unable to even switch on my video because I'm logged in there also.
Okay, you can, I think we will be completing this because this only one case that we have finished.
You continue later, madam. Just to let me say, because I have to talk there, madam. Please understand. Otherwise, you're part of Oxy and definitely not a problem in you going ahead with
No problem, no problem. You can complete the vote. We have finished, almost finished. It's over.
Yeah, okay.
You can.
It's really a proud privilege, definitely, to propose the vote of thanks on behalf of Oxy, as in the capacity of Secretary of Oxy and for the TNFOG representing that. Very, very sincere thanks to all of you, each and every faculty who has participated, each and every delegate who has been here. It has been a wonderful program, excellently organized. I'm logged into both the programs. I don't know which one to watch. This is really what to say, very well chosen topics which people really are not so very comfortable with handling. So definitely you have demystified the sexuality in female, madam. And hats off to Dr. Neeraj Yadav and Dr. Jairani Kamaraj, madam, for organizing this wonderful CME. Thank you so much for involving Oxy and TNFOG. If I have left out anybody in this thanks, it is only because of an error. Kindly excuse me. And I hope you understand that I'm already logged in another program. That is the purpose of this interference. Sure. And I would like you all to continue for some more time to enlighten the delegates. Thank you so much, Jairani, madam.
Thank you.
And a very sincere thanks to Microlabs for their sponsors also.
Yeah, that's it.
Thank you so much. Thank you.
Thank you, Vijay.
Bye.
So I think we have also concluded our panel discussion. It was very elaborate. And I think Kavita can give an inputs. And if there is any question out there, we are ready to answer.
Can I add one point, ma'am, which I do in clinical practice? See, normally you were talking about vaginismus, that first and second degree. Once the woman gets confidence after penetration with her own fingers, we usually suggest with lubricants to go on the women on top position. So she can control the penetration, and that way it gives her the confidence to finally indulge in penetrative intercourse. So that particular positions also come in as useful suggestions to them.
It's very correct, Priya, that we do always for the vaginismus as sex therapy that includes the stages of penetration that they have to plan. That will help them to have a mental compliance, because you're treating her physically, but the mental part also has to be there because she's not now inclined towards sex. Sex is a phobia for her. So for a mental compliance to be taken care, we give this therapy. That is what Marston Johnson gives us a sex therapy, that's a sensate focused therapy, which will help them to get through the psychological inhibitions they have with the sex. So when both the things can be taken care, will give them a better sexual performance and correcting this problem and have a proper sex. So I
Thank
think
you, Jairani ma'am.
Thank you, ma'am.
Yes, I think it was a long and
It's a
wonderful
real
session.
long Saturday.
Yes. But
Yeah, it's
since
a long
because it
Saturday.
was this topic, it was fine enough to sit and listen such a long time. It was a wonderful discussion, and the points, and I think you didn't leave alone anything. There was nothing which went untouched. So and even the panelists were like equally contributing. One very close to my heart is the vaginismus. I think you gave a very clear picture of what to be done for vaginismus, because many a times I see these women getting through many surgeries, Fentons, Botox, and so many things without even going for a psychological counseling or this, as you told, like dilators and changing the sexual positions. These are never been advised. So very nice discussion. And the last bit, the vulvodynia, is something which again there's a bit of confusion, and you touched upon that topic also. And thank you so much for this entire webinar and the panel discussion.
A very special thanks to all my energetic, young, youthful, and dynamic young panelists. And I wish you all to succeed in the sexual health practice, sexual medicine practice, and take all these things to every part of our country.
Thank you so much for the
Thank you so much,
opportunity,
madam,
ma'am.
for this
This was a
opportunity,
really
madam.
very, very nice
Yeah.
discussion. I totally enjoyed it.
Yes, madam.
Ma'am,
Thank you,
enjoyed
madam.
talking
Thank you.
sex with you, ma'am. Really enjoyed talking sex.
I like the way you put it very
fault.
nicely. I like talking sex with you.
Actually,
Surendra, nobody will find fault with me.
You should have taken a topic to speak, actually. To talk
It's
about
nice.
sex more.
It's nice that we end the dysfunction with the greatest, with a nice humor. Though the women who suffers with the female sexual dysfunction go through a lot of mental stress and agony, but we have given them a very important thing for the gynec practitioners to know about it, to learn about it, and to have a eye-opening on this. And I thank Foxy Sexual Health Committee, especially the chairperson, Dr. Neeraj, for giving us this encouragement to have this wonderful webinar. And it is his dream that we have made it today. He had a vision, and we are all into it to complete. I hope that we have satisfied that vision. And a very special thanks to the technical persons, Mr. Sashi, Mr. Ram Sheshen of Micro Labs, for sponsoring this webinar and keeping everything on live. And a very special thank to all the faculties, the chairpersons, the coordinators of all the sessions, and importantly, I'm very thankful to all the delegates. I think more than 200 or 250 delegates have logged in. And
325 is the number, doctor.
How much?
325.
Oh, 320. Wow. That's great.
We've crossed the 300 stage.
Yeah, that's great. That's great. So I hope that we have satisfied all the delegates who have been there. A very special thanks to all the delegates. And we plan to have so many future sessions also regarding sex education, about the FSDs, and also the practical approach to sexual dysfunction.
Thank you.
Thank you, madam.
Thank you, and good night to each and every one.
Thank you, everyone. Good
Thank
night.
you, Kavita. You were missed today.
Happy weekend.
Thank you. You were missed today for us, for our function.
And,
Selva mentioned you.
All the presidents and secretaries of, especially Madam.
Thank you, madam.
Madam Sumati, everybody, I have a special thanks. And we wait to see you all again in future.
Madam, can I say one sentence?
Yeah.
I had a doctor who had severe vaginismus, and first baby, I convinced her that she has to first do it with her fingers and all that, and she conceived. She got a son 6 years back. Now she is come for again infertility and again vaginismus, and now I'm not able to convince her. I really pity that husband whom she's not letting him come near her also.
So you should ask for the history whether they have any marital relationship problem.
Yeah.
No, ma'am,
Modern
he is
thing.
very supportive, and she is like that. And I have sent her
There,
to
you ask for
psychiatrist also for counseling.
It happens many a times. Many IVF failures who come to us, we treat them and they get natural
She
pregnancy.
said she's a doctor also, isn't she, madam?
Yes, that is the thing. That is the joke about it. She is an MBBS doctor.
There. So we're all female. They are not doctors. They're all female. That's how we have to look there.
I have a gynecologist waiting to come for this. It's not
even
just
worse.
doctor.
Anyhow, nice. Thank you so much. I thank wholeheartedly all my panelists and all the team.
Thank
And,
you. Good night, everybody.
Thank you. Good night.
Good night, madam.
Bye.